The subcommittee will come to order. The chair will recognize himself for an opening statement. The Medicare Part D prescription drug benefit is a government success story. Last year, nearly 39 million beneficiaries were enrolled in a Part D prescription drug plan. Competition and choice have kept premiums stable. In fact, in 2006, the first year the program was in effect, the base beneficiary premium was $32.20 a month. In 2014, the base beneficiary premium is $32.42, a 22-cent increase over 9 years, and still roughly half of what was originally predicted. More than 90% of seniors are satisfied with their Part D drug coverage because of this. African American and Hispanic seniors report even higher levels of satisfaction at 95% and 94% respectively. The program has worked so well because it forces prescription drug plans and providers to compete for Medicare beneficiaries, putting seniors, not Washington, in the driver's seat. Part D should be the model for future reforms to the Medicare program. Instead, in its January 6, 2014 proposed rule, the Centers for Medicare and Medicaid Services, CMS, proposes to dismantle the very features of the program that have made it so popular and successful. CMS has taken it upon itself to interpret the non-interference clause in the statute to mean that it can interfere with negotiations between plans and pharmacies. Congress expressly created the clause to prevent CMS from doing what it intends to do in this rule. Yet CMS is choosing to ignore the law. The proposed rule seeks to essentially eliminate preferred pharmacy networks. A 2013 Milliman study shows that preferred pharmacy networks will save taxpayers $870 million this year and anywhere from $7.9 billion to $9.3 billion over the next 10 years. CMS itself says that 96% of the Part D claims it reviewed showed seniors saved money at preferred pharmacies. And nearly 25,500 seniors in my congressional district have chosen Part D plans with a preferred pharmacy network. Yet CMS would take that away from them. Today, the average senior has 35 different plans to choose from this year. This rule would reduce that choice to 2 plans. 50% of the plans offered today will be gone, and the health care that seniors like may go with it. Limiting seniors' choices like this will inevitably lead to higher costs. By some estimates, the restrictions on the number of plans that can be offered could cause premiums to rise by 10 to 20%. Cost to federal government may increase by $1.2 to $1.6 billion, according to a study by Milliman. How is this beneficial? I'm at a loss to understand why CMS has proposed these changes and what problems with the Part D drug benefit it is attempting to solve. I don't see how any of these proposals provide tangible benefits to seniors. But I do see more bureaucracy, less choice and competition, and higher costs to both beneficiaries and the federal government in the future if the proposed rule is enacted. I urge Secretary Sebelius and Administrator Tavenner to rescind this rule. And I welcome our witnesses here today. I look forward to their testimony. Thank you, and I yield the remainder of my time to the gentlelady from Tennessee, Ms. Blackburn.
Thank you, Mr. Chairman. I thank you for the hearing today, and I have to agree with you. Medicare Part D is very popular with seniors. A majority of beneficiaries not only participate in Part D, they express satisfaction with the program, and it is definitely working the way it was intended. I join you in being very concerned about the rule and the proposed rule This is something that would not serve groups well, certainly not my seniors in Tennessee. There are over 250 groups, which include patients and physicians, that oppose the rule. And I would like to submit a letter from an organization, Centerstone, submit that for the record. They provide mental health care in Tennessee.
Without objection,
and I
so
thank
ordered.
the gentleman for yielding the time, and I yield back the balance of my time.
Chair thanks the gentlelady. Now yields to the ranking member of the subcommittee, Mr. Pallone, 5 minutes for an opening statement.
Thank you, Chairman Pitts. The Centers for Medicare and Medicaid Services, CMS, recently proposed program changes to the Part D prescription drug benefit for 2015, and I believe it's important that we thoughtfully examine these changes and the effects they will have on the program and on beneficiaries. Unlike my Republican colleagues' tactics towards the Affordable Care Act, my initial opposition to the Part D law has not stopped me from working to improve and strengthen the program for seniors. In fact, the ACA took important steps to address the inadequacies that first caused me concern. Specifically, we closed the donut hole. So I welcome today's hearing so we can learn from the agency and other stakeholders about what's working and not working in the Part D program, and of course, how we can strengthen the program to work better for seniors and taxpayers alike. Truthfully, it frustrates me that the Republicans are politicizing this issue using alarmist and exaggerated rhetoric to make a politically motivated point. Given the significance of the Medicare program, I hope we can have a constructive and sincere discussion today on CMS's recent proposals regarding the Medicare drug benefit. The committee has a valuable function of monitoring and looking for ways to improve programs under its jurisdiction. However, let's not forget that CMS also plays a role in ensuring that its programs are working as effectively and efficiently as possible. One way it does this is by promulgating regulations to make adjustments and respond to changes in the healthcare landscape and evolving needs. Importantly, part of the federal rulemaking process involves making the proposed program changes available for public comment and taking comments into consideration before finalizing the regulation. Mr. Chairman, there are many positive provisions in this rule, and even if it's not perfect, I do not agree with the naysayers who have called for its dismissal outright. Rather, we should move forward on how best to achieve our objectives for a Part D program that serves its beneficiaries as best as possible. For example, the proposed rule seeks to make improvements to transparency and to reducing fraud and abuse. These are issues I think we can all agree are important to continue to work on. I can also see the value in offering meaningful choices for beneficiaries rather than just more choices, which create unnecessary complexity in making plan choices. Now, there are some policies in this proposed rule that give me pause, in particular the proposed protected classes policy. I think everyone here should share in the administration's goal of lowering prices, but I do worry that the benefits to Medicare may not outweigh the risk when it comes to vulnerable patient populations. So, Mr. Chairman, I just hope that today we can have meaningful discussion about these policies. I look forward to hearing from our witnesses about the rule and how we can continue to improve and strengthen Part D. I'd like to yield now the remainder of my time to Mr. Green, if he'd like.
Thank you. Thank you for yielding to me. And I want to thank the chairman and also the ranking member for having the hearing today. Some of us were on the committee when we drafted the prescription drug plan, Medicare Part D, in 2003. And it was also a very partisan issue, just like the Affordable Care Act. In fact, some of my emails over the years have said that the Affordable Care Act was passed at night. I really remember the vote being left open for about 6 hours, and I think our vote was about 5 a.m. in the morning. My colleague from Illinois knows that. Even Congress can work at night sometimes on both issues. And I also recall that the Affordable Care Act had trouble rolling out. We actually worked with our constituents to help people use community college, community computers to help people access it, even though I considered the plan flawed. Although over the years there's been changes and reform, mainly administration-wise, and I think that's what we're going to see today. While it's clear that Part D programs provided prescription drugs for Medicare beneficiaries who previously didn't have it, there's still room to improve the program. And I have some concerns about individual provisions of the proposed rule, but I support increased transparency and expanded access to affordable pharmacies and cost sharing for Medicare beneficiaries. And again, I thank my colleague for yielding the time. I yield back.
And I yield back, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the Vice Chair of the Subcommittee, Dr. Burgess. 5 minutes for opening statement.
I thank the Chairman for the recognition. Mr. Blum, welcome to our committee today and to our other witnesses. We're happy to hear from you. So December of last year, the end of 2013, marked the 10-year anniversary of the creation of the Medicare Part D prescription drug benefit. Not only has Part D come in at 45% under budget, the Congressional Budget Office has reduced its 10-year projections for Part D by over $100 billion for each of the last 3 years. The success of Part D is largely attributed to its competitive free market structure. I would remind my friend from Texas that different from the Affordable Care Act, the Part D changes were non-coercive and based on free market principles, entirely different from the ACA. So despite a proven track record of success, the Center for Medicare and Medicaid Services has proposed to fundamentally restructure the Part D program, restructure it with a 700-page rule, allowing the government to interfere in private plan negotiations, restrict beneficiary choice of plans, and limit incentives that lower costs for consumers. Only in Washington would there be a big government solution in search of a problem that simply does not exist. The interference by the Center for Medicare and Medicaid Services is projected to eliminate almost half of current Part D plans in 2015. So what effect will that have? Well, it's going to drive premiums higher for nearly 14 million seniors and increase costs across the entire Medicare program. Even more concerning is the proposal by the Center for Medicare and Medicaid Services to eliminate several of the protected classes of drugs under Part D. And we all remember when Dr. McClellan came to this committee and the Democrats asked some pretty incisive questions, and Dr. McClellan was able to defend the Part D program based on the fact that there would be these protected classes under Part D. They were designed to ensure that vulnerable populations of patients have continued access to life-saving drugs. Not all drugs are interchangeable, especially in the case of immunosuppressants. Without this committee getting into the pharmacology of how these drugs work, if we don't understand how they work, how can we change the policy so that and not affect the patient at the same time? The removal of these drugs from protected class status risks the lives of current and future beneficiaries, further jeopardizing transplanted organs and patients' lives. Yet again, the Center for Medicare and Medicaid Services has proposed a policy that is penny-wise and pound-foolish. Not only has the program increased patient access to drugs and made positive effects on the health of beneficiaries, the program has extended the solvency of the entire Medicare program, saving billions of dollars over the past 10 years. So rather than continue a successful program and encourage innovation, now we're faced with a rule to ruin one of the only working parts of our current healthcare system, leaving patients with the short end of the stick. Mr. Chairman, I would like to submit for the record a statement by the National Kidney Foundation and the American Society of Transplant Surgeons, and yield to Mr.
Without
Shields.
objection, so ordered.
Thank you, and I thank my colleague and friend. More than 250 organizations united for a common goal, protecting seniors and individuals with disabilities from harmful changes to Medicare Part D. And that's what your proposed rule actually does. It harms seniors. It gives them less choices. It'll project higher costs. And from an administration that cut $716 billion out of Medicare to propose a 700-page rule on trying to fix something that's not broken, it's disastrous at a time when people are paying more, even in the national health care rollout. It's safe to say when I go to my district, people pay more for now their insurance and get less. And this is just going to fall down to our seniors. I also want to focus on the fact that Medicare D has been successful. I want to focus on medical therapy management issues, that moving that level down that small is just going to hurt medical therapy management for those bigger populations that actually need the care. And I yield the rest of my time to Dr. Cassidy.
Thank you. I'm a doc. And so when I talk to constituents back home about how changes by Obamacare and this administration are going to decrease their choices and increase their cost, I understand the issue. Medicare was cut $716 billion to fund Obamacare. And frankly, when you cut that much, it's got to give. It's going to force beneficiaries to find new health care plans despite the President's promise that you could keep your health insurance if you like it, period. Instead, they get cancellation notices. Now, the Medicare cuts, $300 billion, are to the Medicare Advantage program, and now I understand that there's a further 3.55% cut on top of the cumulative 6.5% cut that the industry has already suffered. It's a very popular program. If you cut funding, seniors have less choice and increased cost. Moving forward, we must preserve that and decrease those costs. We need policies that help seniors, not threaten access and choice. I look forward to the questioning. Thank you. I yield back.
Chair thanks gentlemen and seeks unanimous consent to enter into the record a letter from 60 Plus Association. Without objection, so ordered. Chair now recognizes the ranking member of the full committee, Mr. Waxman. 5 minutes for
Thank you, Mr.
statement.
Chairman. Today's hearing will focus on the Medicare Part D drug program. When President Bush signed the Part D benefit into law, Democrats had many concerns. We thought the structure of the law was too confusing for beneficiaries. We thought the donut hole was bad for seniors, and we felt the law did not do enough to reduce drug costs, and most of us voted against it. But, Mr. Chairman, we didn't find dozens of ways to sabotage the program. We didn't send out massive document requests in order to delay and intimidate contractors. We didn't shut down the government to try to force its repeal or vote over 40 times to repeal the law. Instead, we worked with the Bush administration to make sure our constituents could get the benefits they deserved. And ultimately, as part of the Affordable Care Act, we improved benefits, closing the Part D donut hole. Mr. Chairman, your constituents and the nation would be much better off if your party took a similar approach to the Affordable Care Act. We improved the Part D law, but there are still adjustments we can make to strengthen the program for both beneficiaries and taxpayers, improving transparency and addressing fraud and abuse. CMS recently proposed a rule that would make some of these changes. I appreciate the agency's efforts. They show that the administration continues to work to improve Medicare for seniors. The proposed Part D rule provisions would increase transparency and increase access to community pharmacy services. Many community pharmacies have been unable to participate in Part D plans' preferred networks, even if they are willing to meet the plan's preferred prices. CMS proposes to allow any pharmacy who can meet the plan's prices to participate. This change would increase pharmacy access for patients, particularly in underserved communities where patients may not have access to preferred pharmacies. CMS has also proposed simplifying beneficiary choices under Part D. CMS and patient advocates have long noted that seniors find the array of plan choices dizzying and that plans are using the multitude of choices to segment risks and maximize profit. It makes sense for both the patient and the taxpayer that CMS address these matters. There are other places where I would like to see the agency rethink its approach, in particular the 6 protected classes policy. I share the administration's goal of lowering prices and ensuring that Medicare is able to get the best deal possible. CMS has correctly observed that eliminating some drugs from the protected classes category would allow Part D plans to negotiate for lower prices. But it is hard to ignore the concerns of patient groups and Medicare advocates that these changes will make it more difficult for seniors to get the drugs they need. There is a better way. Adopting my Part D drug rebate bill, the Medicare Drug Savings Act would be a much sounder and beneficiary-friendly approach. This bill would allow Part D to get some discounts on drugs for low-income seniors that Medicaid and private sector purchasers receive. It would, according to the CBO, save over $140 billion over the next decade. The administration was correct to include this provision in its new budget. It's a common sense idea that would save taxpayers billions of dollars without affecting access to Part D drugs for seniors. Mr. Chairman, I'm pleased that Deputy Administrator John Blum is here today to explain CMS's approach in the Part D rule. I look forward to discussing how we can improve Part D for seniors and reduce taxpayers' costs, and yield back the balance of my time.
Chair thanks the gentleman, and again seeks unanimous consent to enter a letter to Administrator Tavener from a coalition of 250 organizations on Medicare Part D. That objection so ordered. We have on our first panel today Mr. Jonathan Blum, Principal Deputy Administrator, Centers for Medicare and Medicaid Services, U.S. Department of Health and Human Services. Thank you for coming today. You'll have 5 minutes to summarize your testimony. Your written testimony will be placed in the record. You're recognized for 5 minutes for your opening statement.
Thank you. Chairman Pitts, Ranking Member Pallone, members of the committee, thank you for the opportunity to discuss our thoughts on ways to improve the Part D drug program.
Just pull that a little closer to you if you can. Yeah, thanks.
We believe the Medicare Part D program has never been stronger. All Medicare beneficiaries have many plan choices to select from. Premium growth has been flat, and the Affordable Care Act took strong steps to close the Part D coverage gap, or donut hole. By 2020, the gap will be completely closed. In general, Medicare beneficiaries are satisfied with their drug coverage, and there is growing evidence that the Part D drug benefit has led to some decreases in other program costs. While Medicare Part D is strong, we also see many vulnerabilities that can and should be addressed. This year, Medicare Part D will cost more than $70 billion, or about 12% of total program costs. According to CBO, total Part D spending is projected to grow dramatically faster than other parts of the program. These projected spending trends, as well as other vulnerabilities, led us to take a comprehensive review of the program and to propose in an open and transparent way some changes to our current regulations. According to our actuaries, the proposed rule will reduce overall program costs and Part D premiums. In addition to rapid spending growth, we see other vulnerabilities in Part D. First, while we see broad measures of beneficiary satisfaction, CMS receives far too many complaints from beneficiaries. In 2013, the program received over 30,000 complaints from beneficiaries regarding their Part D coverage, far too high. Second, we see very high rates of inappropriate prescribing. While we are very, very sensitive to the concerns we have heard over changing the protected classes designation for 3 drug classes, we have to acknowledge the requirement for Part D plans to cover all drugs in these classes with very little restriction has led to harmful overprescribing, particularly antipsychotic drugs, to sedate nursing home patients. Third, the program has too much prescriber fraud. This agency made a commitment to the Senate Homeland Security Committee to reduce this fraud. This proposed rule honors that commitment. Fourth, we have seen too many Part D sponsors have significant compliance issues that have resulted in harm to Medicare beneficiaries. Fifth, we see weak data evidence that preferred pharmacy networks always leads to cost savings for beneficiaries and the taxpayers. Six, while most beneficiaries have many plan choices, the evidence suggests that beneficiaries rarely change plans, even though they could reduce their out-of-pocket costs by changing plans. We support private plan competition in Medicare Part D, so long as beneficiaries can understand their choices and make changes easily. And seventh, CMS, under current regulations, cannot share detailed Part D claims data with outside researchers. We believe this data, if shared appropriately, can make the program even stronger. Our proposed Part D rule is designed to address all these vulnerabilities and to make the benefit work better for Medicare beneficiaries. In short, we believe that we must celebrate Part D's success, but also take a critical look at its vulnerabilities and take action where we can. The status quo is hardly perfect. However, we deeply respect the views of those who have stated their concerns and opposition to the rule, particularly patient groups, and their concerns over the changes to upper protected class definition. CMS will listen very carefully to the views of all Part D stakeholders and partners. We will make our final decisions after carefully reviewing all stakeholders' comments. Thank you. Happy to address your questions.
Chair thanks the gentleman. And we'll now go to questions and answers. I'll begin the questioning. Recognize myself 5 minutes for that purpose. Mr. Blum, nonpartisan experts are warning us that millions of seniors will see higher cost and fewer choices if this regulation is finalized. Seniors in my district tell me how much they enjoy the Part D program, many times when I talk to them. As you acknowledge in your testimony, the Medicare drug benefit is under budget, and 94% of seniors are happy with it. Why would CMS propose this regulation if everyone is telling us that it is going to force seniors to lose their plans, decrease access, and increase cost?
Well, a couple of points, Mr. Chairman. We see the overall Part D program being a tremendous success. But the nonpartisan CBO projects that Part D spending in the next 10 years will grow faster than the other parts of the program. It's the fastest line item for the Medicare program. The entire Medicare program since the Affordable Care Act has dramatically been reduced, but for Part D. Part D is projected to be the fastest growing program. Now, CMS's proposed rule is a consistent path for us to simplify plan choices, to reduce, kind of extra plans being offered by the same plan sponsors. CMS started this work back in 2010. We heard the same concerns from the plan industry, the PBM industry, that those changes would raise premiums, decrease choices, create greater dissatisfaction. That hasn't happened. As you point out during your opening statement, the Part D premium has stayed flat, while at the same time we have reduced kind of extra plan choices dramatically, cut them in half. And looking at the past track record, the arguments we're hearing today were similar arguments that we heard back in 2010, but those arguments haven't been, those arguments back in 2010 did not prove true.
Given the fact that the President's health care law cut $716 billion from seniors' Medicare program, and we're already seeing how those cuts are negatively impacting seniors throughout the country, why should they believe that this proposed rule won't hurt them even more?
Well, I think going back to the payment reductions that were passed in the Affordable Care Act, while we appreciate that there is now reduced spending within the Medicare program, we see that every signs on quality have increased. We see more private plans wanting to come into the program. We see premiums remain flat. The Part B premium this year was negative. Part D premiums for plans have fallen, not risen. So we appreciate the fact that we are paying less today than we paid for some services before the Affordable Care Act, but every quality sign that we track, that every quality sign that we measure has gone up, premiums have gone down, and so we believe very strongly that beneficiary care, beneficiary costs have not been impacted by these changes.
The law includes a non-interference clause, which prohibits the government from interfering with competition. And this has helped to prevent CMS from interfering with negotiations between drug plans and pharmacies. Such a prohibition has helped reduce costs for our seniors. I and my colleagues read your regulation to violate the non-interference clause. In fact, department officials have weighed in against the very interpretation included in the proposed rule. I would ask that you open the document book, document 1, in the document binder before you. This memo is from the HHS Inspector General, and I'd ask you to read the highlighted portion of the document. You can go ahead and read that out loud.
So this is a statement from Carrie Weems back in 2008. We agree that the Act prohibits the government from interfering with negotiations between PDP sponsors and pharmacists and from instituting a price structure for the reimbursement of covered Part D drugs.
Now, did you or agency staff specifically review the Inspector General's memorandum before issuing your proposed rule?
I don't know. I can check. I personally did not, but I think it's important for us to explain why we chose to propose this change. CMS, in the course of day-to-day interactions with plans and pharmacies and other entities, gets drawn into individual contract disputes. Plans ask us to arbitrate contract disputes with pharmacies and other entities. Pharmacies ask us to arbitrate disputes from Part D plans, and we agree the statute is clear. CMS shall not interfere with the price structures. What we tried to do is to articulate when and will not CMS interfere with these contract disputes. Now, our challenge is on a day-to-day basis that plans and pharmacies ask us to arbitrate, and we wanted to propose a clear definition, not to degrade the non-interference clause, but to strengthen it to make sure that we are absolutely clear with partners, stakeholders, when CMS won't arbitrate contract disputes. But we have no intention to negotiate price structures. The law is very clear. During my time on the Senate Finance Committee that I had a hand in helping to draft that provision, I understand the intent. I understand why that was included.
Well, you know, I'm not sure it's responsible for agency staff to issue a rule that completely contradicts the written legal opinion of the HHS Inspector General. So with that, I'll recognize the ranking member, Mr. Plone, 5 minutes for questions.
Thank you, Mr. Chairman. You know, I know you mentioned, Mr. Chairman, the Medicare Advantage changes in the ACA, and as you know, nearly every Republican in the House of Representatives voted for or supported the very same changes or savings. In fact, these savings were part of the Republican budgets written by the House Budget Chair Paul Ryan in 2011, 2012, and 2013, and these same policies put in place by the ACA were continued in these budgets, and the majority of House Republicans voted for them in each of those years. But let me ask Mr. Blum, if you listen to the critics of the proposed rule that you're discussing today, it sounds like the end of Western civilization as we know it. And the refrain we keep hearing is that most beneficiaries are satisfied and costs are lower than anticipated when the program was enacted 8 years ago. Therefore, we should make no changes. And today's hearing is titled Messing with Success. But frankly, I believe that we should continually seek to improve Medicare for beneficiaries and taxpayers. It seems strange to me that people would want to block changes that could improve the program. In fact, organizations representing these so-called satisfied beneficiaries that we keep hearing about, such as the National Council on Aging, National Committee to Preserve Social Security, and Families USA, strongly support many of your proposed changes. So could you comment on why CMS chose to move forward a proposal to further strengthen Part D at this time?
Well, we see the program being tremendously successful. We also see that the program has many vulnerabilities. We receive recommendations from the IG frequently for us to take stronger steps to reduce prescriber fraud in the program. We see that while the Part D premium has remained stable over the past several years, that's only one part of Part D's costs, and the Part D premium doesn't measure the complete cost of the program. Part D is projected to spend faster than other parts of the program, dramatically faster than the Part A program, the Part B program. We feel it's our responsibility to propose changes to improve the operations. We also feel that it's our responsibility to do it through propose and notice comment period. We want to create a conversation about the best ways to improve the Part D program. We respect and we will carefully review the comments, concerns, the criticisms, but for us to argue that the Part D program is perfect, the status quo is perfect, is contrary to what we see our obligations to this committee, to the Congress, and to the beneficiaries that we serve.
Well, I certainly agree. We've also heard that the unfettered competition in the Part D program is responsible for bringing costs down below initial projections, and that the CMS rule is messing, I think the word is, with competition. But could you comment on what has led to the lower costs in Part D? I know you have already, but maybe a little more.
Well, 2 points I think is important for us to state on the record. If you speak to our CMS actuaries and ask them what has accounted for the lower costs than projected back in 2003, I believe the #1 answer would be the fact that we have much more generic prescribing happening in the Part D program, and the fact that we have fewer brand new breakthrough medications right now on market than the CMS actuary CBO staff projected back in 2003. So it's not necessarily private competition that has caused the lower Part D cost trends previously, but the fact that we have kind of fewer brand name drugs coming onto the program. I think it's also important for this committee to understand that the Part D program is not a truly competitive model, that it's not simply that CMS pays a fixed capitated payment to Part D plans, they can negotiate, set benefits best they see fit. Medicare, in many respects, is a cost-based program. For the low-income beneficiaries, Medicare pays just about the full cost of the benefit, not based upon a fee schedule, but based upon the prices Part D plans negotiate. For beneficiaries that exceed certain thresholds, the catastrophic limit, Medicare pays just about the full cost of those drugs past that limit. So to say that Part D is competitive in kind of purely sense doesn't meet the statutory definition of the program, and I think what our actuaries tell us is that the primary reason that Part D spending has been lower than projected is the fact that we have more generic prescribing due to the fact that we have fewer new brand name drugs brought to market.
Mr. Chair, thank you. Mr. Chairman, I have 4 letters. I'd ask unanimous consent. I have 4 letters in support of the rule and the provisions that foster greater transparency and competition, as well as enhanced beneficiary protections from beneficiary advocacy groups, including the Medicare Rights Center, Families USA, Independent Specialty Pharmacy Coalition, and the National Community Pharmacists Association.
Without objection, so ordered.
Thank you.
Chair thanks the gentleman. Now recognize the Vice Chair of the full committee, Ms. Blackburn. 5 minutes for questions.
Thank you, Mr. Chairman. Thanks, Mr. Blum, for being here. Avalar has said that the changes you're going to make would eliminate 39% of all of the enhanced plans by 2016, and that would be 214 of the current 552 enhanced PDPs to be terminated or consolidated. So what would you say to the seniors in my district who like the plan that they have but cannot keep it if you get your way?
So a couple of things, Congresswoman. First is that CMS since 2009 has put in place a strategy to reduce the number of kind of extra plans that sponsors provide. When we started that process back in 2009, 2010, we heard
You're doing this through the rules.
Correct.
Okay, let me ask you this. Avalar also said that the regulation would impact 7.4 million of the 7.9 million Medicare beneficiaries who are enrolled. That's 94%. So why would you and the President support a regulation which is going to disrupt 94% of seniors in Medicare Part D who have a plan that they like and would really like to keep it, but you're not going to let them do that?
So I think it's important to think about the history of the marketplace. Before the donut hole was closed, Part D plans oftentimes offered kind of supplemental benefits to fill in that donut hole. The donut hole is now being closed due to the Affordable Care Act. By 2020, the donut hole will be completely closed. There have been very strong steps so far to close that donut hole. We see little opportunity for Part D plans really to distinguish themselves from other plans those
so you
same
see
sponsors
this as
offer.
an opportunity?
We see this as a way to simplify the Part D program, to make it much more easier to navigate.
So by limiting choice and options, you see that as a simplification and a way to improve this program?
And I think some of the concerns that I hear oftentimes from the beneficiary communities that there is many Part D choices, too many to choose from, and we know from academic literature that the more choice, more confusion.
So you think people are confused?
I think
that seniors are confused and they need CMS to simplify this?
I personally hear tremendous confusion from the beneficiary community.
Let me ask you another question. You've talked about actuaries a lot. Are you listening to actuaries or enrollees?
We listen to both beneficiaries
to both. Okay.
And to our career actuaries.
Okay. Well, you know, the surveys show that 95% of the seniors are satisfied with their plan, and Part D is estimated to cost 48% less than initially estimated by the CBO, and Milliman has projected that if your new rule goes into effect, the federal government will be on the hook for $1.6 billion more than expected in 2015. So where are you going to get the money?
So I think a couple things. I think we see a future for the Part D program that is growing very quickly, 10% per year. That is dramatically faster than other parts of the program. So to say that we shouldn't take a critical look at the future, we don't agree. We heard the same concerns back in 2010 that premiums would skyrocket, beneficiaries would be left by their plan when CMS started to consolidate.
Yeah, we heard that about the Affordable Care Act, and that indeed is happening. I tell you, I have plenty of stories I can share with you there. Well, if Part D is not broken, then why do you think you need to go put something in here that's going to cost more, limit options, take seniors out of their plans? You know, it doesn't make a whole lot of common sense, Mr. Blum. And I think that what we would like to do is see seniors who have a product they like, they're satisfied. Bear in mind, Medicare is something seniors have had money coming out of their paycheck every day of their working life and going into a Medicare trust fund. And they have prepaid their participation in this program. And I think that CMS needs to be listening to those enrollees and maybe paying less attention to these actuaries that obviously are going to give you. Let me ask you this, what's your goal? What are you trying to achieve by this? What's your outcome?
I think we have several goals. We want to reduce the prescriber fraud in the program. We want to make the benefit less confusing, more clear to our beneficiaries. We want to make sure that when the program pays the majority of costs for low-income beneficiaries, that we're paying the best possible rate. When we see preferred pharmacy networks being created, we want to encourage innovation, so long as those cost savings get passed on to our beneficiaries, passed on to the taxpayers. So Part D, yes, has been tremendously successful, but we do not think it's perfect, nor do we get that feedback.
My time has expired. One last question. Can you cite for me the statute that gives you the opportunity to go in and settle these disputes between the manufacturers and the pharmacies? Yield back.
Sorry, is that a question? Or
did you want to respond?
We're happy to provide our legal clarification. We see that the changes to the non-interference don't weaken, but they strengthen. And on a day-to-day basis, we're pulled into many disputes that we feel that we need to provide clear rules.
Okay, the chair thanks the gentlelady, and now recognize the ranking member of the full committee, Mr. Waxman, 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Blum, there's a lot of concern about the proposed rule removing 2 classes of drugs, antidepressant and immunosuppressants, from the list of protected classes. I'd like to hear your rationale. I know there are cost concerns, and cost concerns are always legitimate. When I did my oversight work on Part D in 2007 and 2008, my investigations also revealed that prices for the drugs on the protected classes list were much higher than they should have been. But I take seriously the concerns that have been expressed by patients that removing drugs from the protected classes list will mean that Part D plans may not cover them and seniors will not be able to get the drugs they need. Give us your rationale here.
Well, I think we came to this proposal with difficulty, with much analysis, and to kind of weighing the pros and cons for a proposed change. And one of the reasons why we felt comfortable to take a careful step towards lifting the class definition is that the Part D program has many protections built into place: the appeal system, transition policy, the very rigorous formulary review that we do for Part D plans. We cover drugs in about 140 drug classes. and we have 6 classes that are now protected. And other drug classes that treat very important conditions, diabetes, hypertension, congestive heart failure, don't receive this designation, yet we don't hear the concerns regarding beneficiaries having access to the drugs they need.
Well, there are a lot of concerns being expressed about this, and I appreciate your efforts to reduce the taxpayer costs. And I know you're serious about making sure seniors can get the drugs they need, but I believe there's a better way. And I've introduced in the last 2 Congresses the Medicare Drug Savings Act that would end one of the worst giveaways that was included in the original Part D bill. For people who were covered by Medicaid before Part D, there was a rebate for these dual eligibles. And when Part D was adopted, suddenly that rebate ended and the prices of those drugs went up, so that the Medicare program paid a much higher price. It was a sweetheart deal. It resulted in a substantial drug manufacturer windfall at taxpayers' expense. My bill would reverse that windfall, adding drug manufacturer rebate so that Medicare Part D prices are no higher than prices in programs like Medicaid. Do you have any thoughts on this rebate bill?
Well, I think the President supports the legislation. In his last budget, the President proposed a very similar change to your legislation to enable the Part D program receive better prices for drugs that were previously paid much less when the beneficiaries received their benefits through state Medicaid programs.
That would not interfere in any way with any of the drugs that people would get. It would just mean a huge savings for those drugs, and restoring the price we paid for those drugs that the manufacturers received prior to Part D. We've heard a lot of concern about Medicare beneficiaries, and I know that, Mr. Chairman, your side of the aisle talks a good game when it comes to being concerned about federal spending. I'd like to suggest that our committee look at this opportunity to take action and pass this bill, Medicare Drug Savings Act, which would cut beneficiary costs, protecting seniors, make sure they have access to drugs. Mr. Blum, I've heard a great deal about CMS's discussion of the non-interference provisions in the proposed Part D rule. Part D statute states Secretary may not interfere with the negotiations between drug manufacturers and pharmacies, and PDP sponsors may not require a particular formulary or institute a price structure for the reimbursement of covered Part D drugs. So we have a witness that has gone on to suggest that your rule rests on a questionable legal foundation, violates the intent of the Congress. I'd like to understand this proposal a little better. Does your proposal rule interfere with negotiations between drug manufacturers and pharmacies?
No.
Does your rule interfere with negotiations between drug manufacturers and PDP sponsors?
No.
Does your rule require a particular formulary?
No.
Does your rule institute a particular price structure?
No.
So it would seem to me that your rule does not do anything that the Part D statute prohibits you from doing, yet the mere specter of the word non-interference has set some industry groups ablaze. Could you briefly explain what your rule does in this area? My understanding is that the proposed rule merely states that whatever prices are, they all have to be reported consistently. Is that correct?
Correct. I think we want to make sure that we are clear when and when won't the agency will become involved in how Part D plans operate. As I expressed earlier, we often get pulled into disagreements, contract disputes. Our principle is to make sure that Part D plans honor the requirements that they have to have complete pharmacy networks, complete pharmacy access standards. But to me and to the agency, this proposed change clarifies what we believe the clause should mean in operations. To us, that works to strengthen the requirement, not weaken it. But we have no intention to interfere in the price negotiations between Part D stakeholders.
Thank you. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentleman, Dr. Burgess, 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Blum, again, thank you for being here. If I understood correctly in your comments to Chairman Pitts, You said that costs are going down. You extolled some of the virtues of the Part D program, and then the next breath you said some of the fastest growth is projected to be in the Medicare Part D program. It reminds me of the old line from the Marx Brothers movie, who are you going to believe, me or your own eyes? It almost can't be both ways.
Well,
one or the other is going to be
clarify,
true.
Please. So looking back, Part D has cost the taxpayers, cost beneficiaries less than what CBO and the CMS actuaries projected back in 2003. That is true, and that's a great statement for us to make together and a reason to celebrate Part D's success. When you look at CBO's current projections for the future, not the past, but the future, Part D total spending, not just the Part D premium, but all the pieces that the program pays, the low-income subsidy, the reinsurance, that is the fastest part of the program.
Correct, but you just have to ask, what is that based on? So let me ask you.
Let me that question.
Let me ask you. When you have this proposed rule that's some 700 pages that I assume that you have read and approved,
Yes.
Is that correct?
Correct.
Can you provide the committee with a cost analysis that you did for this rule?
Sure. By requirement, we have to do an economic estimate. This rule is significant, so per OMB process, we put our estimate.
Have you provided that to the committee?
That's part of the rule.
Okay. Have you provided it already, or is it coming?
We're happy to send a copy of the rule to you.
Let me ask you this. In that, is there also going to be the delineation of the legal justifications for proposing the rule?
The proposed rule went through our general counsel. They cleared it. We're happy to answer any questions regarding their legal views regarding the regulation.
Well, and we need that. I mean, it's critical to our discussion. On the non-interference that's come up several times this morning, the non-interference policy, the cornerstone of the Part D program, under the proposed rule, CMS reinterprets this part of the statute, asserting the language of the law does not apply to negotiations between pharmacies and prescription drugs sponsors. So in my mind, there's some confusion as to why, after 10 years, your agency felt that it must now reinterpret the non-interference clause. What has changed that propelled you to make this distinction?
Well, I think we interact with our Part D plan sponsors on a day-to-day basis. We approve, we review, we have a very rigorous process.
Do you have evidence to which you can point and provide to this committee why you changed?
Yes, we're happy to do that.
I would ask you to submit that for the record. And how do you anticipate now the Center for Medicare Medicaid Services intervention in these negotiations to improve the program? What is your expectation of improvement? Can you provide that to the committee?
Absolutely.
Are you aware of the requirements within the oft-mentioned Affordable Care Act? Are you aware of the requirements to keep the proprietary contract terms confidential? That's Section 3301 of the PPACA. And it seems to me it would be contrary to the policy you are proposing in the Part D proposed rule.
We're happy to review that section of the statute to make sure that we're consistent.
And again, you need to do that, and it needs to be detailed. Let me just ask you again about, were you or Administrator Tavernier or Secretary Sebelius, did you receive any legal memoranda? Was any legal memorandum prepared for you that provided you the ability to proceed forward with this rule?
Not sure about legal memorandum.
Let me restate that to the proposed non-interference interpretation.
So let me be clear. All major regulations go through rigorous review through the department. That includes our general counsel staff. The general counsel cleared the regulation, which means they believe that CMS had the authority.
And you received a memorandum to that effect?
I don't know, but I can check for you, sir.
The committee needs that. Let me just ask you, were there any doctors on the panel that evaluated the immunosuppressive drugs relative to the proposed protected class?
The CMS Chief Medical Officer for Medicare was part of that panel. And
is that
by the way, he was the same Chief Medical Officer that helped design the protected classes back in 2005.
Well, has there been any breakthrough or change in the science on immunosuppressive drug treatments since 2005 that many of us on the committee might have missed?
Well, I think we recognize the very strong views of patient groups, physician groups. We understand this is a significant change.
Mr. Blum, I'm going to run out of time, but with all due respect, it's not just strong views. You give the wrong immunosuppressive, you lose the graft. This may be a graft that's been given by a living donor or someone who donated upon their demise, but you reject a graft. That's a big deal. And it costs you at CMS a ton of money to then put that kidney patient, graft recipient, back on dialysis after they reject their graft, or worse, then pay for another transplant some point down the road. I mean, that's an incredible inefficient use of funds. So it's hard for me to believe that you really have the cost-benefit analysis in hand when this type of behavior is allowed to go on at CMS. Thank you, Mr. Chairman, for your indulgence. If the gentleman wishes to respond, but I'll.
I pledge the agency will carefully review both the clinical arguments and the concern from patient classes regarding the changes to the protected classes. We understand this is a change. We understand that there is clinical implications, and we will take a very careful look at the comments and the thoughtful arguments coming to us during the comment process.
Chair, thanks, gentlemen. Now recognize the gentleman from Texas, Mr. Green. 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Mr. Lum, for being here. I understand that some plans have used significant incentives, for example, zero cost sharing, to steer patients to mail-order pharmacies. I believe patients, of course, should be able to choose how the pharmacy setting that best meets their needs, whether it's mail order or bricks and mortar. However, CMS found that these incentives caused increased demand for mail-order prescriptions sufficient to disrupt timely delivery of prescriptions to patients. In a retail setting, the beneficiary often is notified of a problem with a prescription in real time or within hours, but when it happens with a mail order, the time it takes to find, communicate, and resolve the problem may delay the delivery date and resulting in gaps into the therapy. I believe that timely access to medicines are critical for patients. I understand CMS is proposing to establish requirements for timely fulfillment of prescriptions for mail-order pharmacies, as well as for home delivery services at retail pharmacies. This would provide consistent expectations for beneficiary access to drugs. Mr. Bloom, when you proposed these standards for the timely delivery, did you come up with these standards, or were these guidelines already in existence that you used to develop your proposed standards?
Well, I think we looked at common standards for any kind of mail program. We believe strongly that we should have both pharmacy networks and mail order options to our beneficiaries, that both should provide value to our beneficiaries and provide clear standards. We want to make the options stronger for our beneficiaries, to work better for our beneficiaries. We want to make sure that beneficiaries understand the benefits of preferred pharmacy networks, community pharmacies, and mail order pharmacies to ensure that both the beneficiaries see clear benefits from different delivery options, but also the taxpayers. And I think more importantly, we want to make sure that plans operate with consistent standards. We receive complaints from beneficiaries regarding the timeliness, the accuracy of drugs being shipped to them by mail. We think it's appropriate for all plans to compete on a level playing field to ensure that they're providing consistent care, consistent delivery to our beneficiaries.
Okay. Beneficiary groups are strongly supportive of ensuring timely access to needed medicines, whether provided by a pharmacy counter or the mail order. Could you further elaborate on the proposal and the rule and why CMS believes this is an important beneficiary protection to pursue?
Well, I think we right now have standards for pharmacies to fulfill drugs in a timely manner. We believe that similar kind of timely standards are appropriate for mail order pharmacies as well. We want to make sure that beneficiaries receive timely, delivery. We want to make sure that we have clear standards. But our goals simply are to provide uniformity throughout how the benefit is delivered and to ensure that plans compete in a kind of transparent way.
Okay. Mr. Chairman, that's my only questions, and I'll be glad to yield back.
Chair, thanks to the gentleman. Now recognize the gentleman from Illinois, Mr. Shimkus, 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Blum, it's good to see you again. We've worked together before, and welcome. I go to schools a lot, and talk about the Constitution, and so these questions are meant just as a position of a constitutional basis of what's Article 1, which is us, Article 2. And the basic premise, even I taught government history, was that the administration enforces the law. That's the job of the administration. So these questions are posed based upon a real concern out there in America that this administration does not enforce the law or picks and chooses which pieces of the law they want to enforce. So let me begin with stating that, as you know, the statute clearly states that CMS may not interfere with negotiations, and I quote, between drug manufacturers and pharmacies and PDP sponsors. I was here, as a few of us were, when Part D was passed. That was an intentional to put that in the law to ensure that CMS would not interfere with any of these three parties. Can you tell me why CMS has chosen, based upon this proposed rule, to go against the law as Congress intended?
Well, I think on a kind of practical basis, in overseeing the Part D program on a day-to-day basis, we constantly or frequently get asked to intervene in contract disputes by plans, by hospitals, by pharmacists. And so we, don't necessarily always feel that we can simply say, no, we're not going to interfere when beneficiary access is a concern. We have no interest to negotiate prices between Part D plans and pharmacies and drug manufacturers, but on a day-to-day basis, particularly when a...
Well, let me, and I appreciate it. Wouldn't it be a better response if you feel the need to do that than to have someone sponsor a piece of legislation and correct the law?
Well, I think we...
I mean, constitutionally. I mean, just in the real world of how we teach our kids, that would be the correct answer.
Well, I'm not a constitutional lawyer, so I can't speak to that process with authority. But what I can articulate is the day-to-day challenge of how we operate the program, how we get drawn into individual disputes. We're open to the best ways to...
Well, let me follow up, because I got two more questions that just kind of follow on with this. In the original final Part D regulations published in 2005, CMS separately responded to comments on its original proposed regulation as follows. As provided in Section 1860D-11I of the Act, we cannot intervene in negotiations between pharmacies and Part D plans. And again, in the same document, as provided in Section 1860D-11I of the Act, we have no authority to interfere with the negotiations between Part D plans and pharmacies, and therefore cannot mandate that Part D plans negotiate the same or similar reimbursement rates with all pharmacies. So if that was the ruling from CMS based upon the law, how can the agency today say it is not unlawfully interpreting the non-interference clause when CMS clearly stated in 2005 that it does not have the authority to negotiate between plans and pharmacies?
Well, I think 2 points, Congressman. One, we're happy to provide our legal justification to this committee to how we got to our proposal. But second, the 2005 regulations were drafted at a time before CMS had experience with reviewing, negotiating, and approving competing Part D plans. When I was on the Senate Finance Committee, I think the working assumption would be only a handful of standalone Part D drug plans would choose to provide coverage. The good news is we have many, many entities wanting to provide drug coverage to our beneficiaries. We have more plans wanting to come into the program every year. And I think the operational realities, the complexities of day-to-day negotiations and interactions with the agency and partners caused us to take this proposal.
Let me finish with this. In the preamble discussion in the final regulation issued in April 2010, CMS stated the non-interference provisions in Section 1860D-11I of the Act explicitly provides that the Secretary may not interfere with the negotiations between pharmacies and PDP sponsors, which would include payment negotiations between the Part D sponsors and pharmacies for MTM services. Mr. Blum, you were director of the Center for Medicare and had operational authority over the Part D program in 2010. Why did your interpretation of non-interference change just
well, I think
4 years later?
I mean, I think with more experience, with more...
but again, that's debate on the law.
Well,
the law is pretty clear.
Well, we understand the concerns regarding the legality of the provision. We're happy to provide our justification. What I can say is that the complexity to oversee this benefit has, caused us to reinterpret certain.
You are not. You're not tasked to reinterpret the law. You're tasked to follow the law. Thank you, Mr. Chairman. I yield back.
Chair thanks, gentlemen. Now recognize the gentleman, Mr. Barrow, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Mr. Blum, for being here. Mr. Blum, for seniors, Medicare is kind of like home. When you got to go there, they got to take you in. When it comes to prescription drug benefits, Medicare D is like home. When you got to go there, they got to take you in. So I want to take stock of what positive has happened before we assess the costs and benefits to seniors, to our customers, as opposed to the institutional interests that y'all have. First off, why do you think the program is costing less than it was originally projected to? What's the number one takeaway we get from you as to why the program is costing less than projected?
Well, I think there's many reasons why the Part D program has cost less than the 2003 projection. I think the first reason is that the Part D program pays for many more generic drugs today than I think CBO or the CMS actuaries projected back in 2003. I think Part D private plan competition also has caused the Part D premium growth to stay moderate, but I think the number one reason is the fact that we have many more generic drugs provided through the Part D program than projected back in 2003 by CBO and the CMS actuaries.
Referring to your secondary consideration of more competition than anticipated, does that also have a role in this? The fact that some folks are providing generics and others aren't, isn't that
well, I think there's
both cause and effect there?
Well, I think there's three kind of primary reasons. The first is due to the fact that we have fewer new blockbuster brand name drugs today on market than I think what the actuary CBO projected back in 2003. I think the second reason is Part D private plan competition. Plans compete very hard for their members, which is why we do not agree that Part D premiums will skyrocket due to some changes in how we oversee Part D plans. And third is the agency is a much more rigorous reviewer of Part D bids and benefit plans coming into CMS. CMS negotiates vigorously with Part C plans, Part D plans, but I think the number one reason that both CBO and CMS actuaries would cite why the costs are lower than projected back in 2003 is the fact that we have fewer new blockbuster brand name drugs than was previously the case back in 2003.
We've taken stock of how we got here. Now I want to take stock of where it is, where you want to take us. Let's talk about the costs and the benefits of the proposed rule. I heard in response to previous questioning that y'all's understanding your cost benefit analysis in the rule. I want to focus for a second on the costs and benefits to our customers as opposed to the costs and benefits to CMS as the institutional interest y'all have in managing the program the way that y'all think it ought to be managed. Can you tick off for me just what you think are the principal costs to seniors of the direction y'all want to take us in? What's going to be the impact as far as they're concerned?
Well, I think we look at costs in a kind of multiple ways. One, we want to make sure that the premiums, Part B premiums, Part D premiums growth remains tempered. Part B premium has been flat and for the first year has, I think, come down, which is due to the changes passed by the Affordable Care Act. The Part D premium in the last several years has stayed flat. We also want to make sure the cost sharing that beneficiaries
my point is it stayed flat without taking the direction that y'all want to take us in. Do you foresee any kind of cost impact to the customers as a result of the proposed rule?
Well, I think we should look back at CMS changes over the past 4 or 5 years. In 2010, we required plans to offer no more than 3 plans, coming down from 5, 6, 7 benefit offerings down to 3. We heard arguments from the same entities that we hear from today that premiums will skyrocket, when in fact they didn't. They stayed flat. So we don't see, based upon prior experience, that from going from 3 plans down to 2, particularly with the Part D donut hole being filled in, that we'll see.
Well, I'm asking you whether or not there have been any adverse impacts to seniors, to our customers, as a result of the proposal y'all are making. I'm hearing you say none. What are the proposed benefits that you think the seniors are going to get out of the proposed changes y'all want to make?
Well, I think they will see greater clarity. They will have greater confidence that the program is doing everything we can to to reduce providers fraud. They will.
That's more of an institutional interest than a customer interest.
Well, I think our customers have an interest to make sure that the program doesn't pay inappropriately.
Sure, but they want to make sure that they're going to have the full range of options they've got too, and they want to make sure that they're not going to lose out on this some other way.
Well, here's the past 5 years. We have more sponsors than ever before wanting to come into the program. For 2015, we continue to see more plan sponsors wanting to come into the program to expand benefits consistent with the past trends. We have heard arguments since the Affordable Care Act that the changes to the Affordable Care Act would reduce plan premiums, when in fact, would raise premiums. They've come down by 14%. So I think we have to look at the past 5 years in order to make judgments regarding the future.
Mr. Chairman, thank you very much. I'd like to follow up on this, but my time's expired.
Chair, thanks, gentlemen. Now recognize gentleman from Pennsylvania, Dr. Murphy, 5 minutes for questions.
Thank you, Mr. Chairman. Despite the success of Medicare Part D, CMS proposed a rule last month that would threaten the health and well-being of our most vulnerable seniors, those with mental illness. Now, having authored the Helping Families of Mental Health Crisis Act, which is H.R. 3717, co-sponsored by many members of this committee, it codifies protected class status for antidepressant and antipsychotic medications. And having written to Administrator Tabner on this issue last month, I'm deeply concerned that the agency's proposal will have huge unintended consequences. Now, this is not one of cost saving or convenience. It's not about swapping generic and brand drugs. Apparently, a panel is what advised you on making these changes, and some consultant. Do you have a list of the panel members who made this decision?
We can provide it. They were CMS career physicians and pharmacists.
Psychiatrists?
I don't know, but I can check for you, sir.
I see. I would think that psychiatric medication, some decisions will be made by psychiatrists. So these are career people, so they work where?
Within CMS, but I want to also clarify.
Are they practicing physicians?
Not sure, but one thing I want to make also clarify is that our analysis is on the web. We propose this change in an open way, and we understand this.
No, I read the analysis, and it does not say who did it, and it has very limited things. So let me offer you something. So is it true that in terms of the proposed rule, there was things from an APA practice guidelines that said the effectiveness of antidepressants medications is generally comparable between classes and within the class of medications. Do you know that's what the register wrote? Are you aware of that?
Yes.
Okay. Is it your view that drugs covered in Medicare Part D, 6 protected classes, are interchangeable?
I think our clinical review is that some of the drugs are today.
No, I didn't ask. I said, let me go on. Did you validate your findings with the American Psychiatric Association?
We proposed these changes in an open way. We are going to listen very carefully to comments from all medical societies,
including the National Association on Mental Illness.
We will.
And the National Council for Behavioral Health.
We will work very carefully with both the clinical patient communities to ensure that our.
How about the National Institute on Mental Health?
We are happy to meet with all stakeholders.
Now, I have in my hand a letter here from the American Psychiatric Association, and I want to read you a couple quotes from this. It says, "We find it particularly disturbing that CMS used selective and improper references to APA treatment guidelines as justification for limiting coverage of these medications." The letter goes on to state, "The selective quoting from our guidelines and flawed clinical logic apparently led CMS to conflate the supposed interchangeability of drugs within the classes of both antidepressant and antipsychotics with overall evidence for efficacy, when this is just one element of a drug's appropriateness for an individual patient." Were you aware that CMS selectively quoted from the APA?
Well, I think one of our principles, sir, was to make sure that we.
Yes or no? Are you aware?
We wanted to make sure that that our analysis was public, detailed.
I see. There's a letter in front of you. You have that letter?
Yep.
As a highlighted section?
Sure.
Could you read that out loud?
CMS also cited the APA treatment guidelines in support of its claim that there is a lack of unique effects for distinguishing individual drug products when initiating drug therapy, and that treatment guidelines generally do not advocate preference of one SSRI drug over another for initiation of therapy. CMS's conclusion is not supported by the evidence it cites. It misinterprets and misrepresents APA's clinical practice guidelines multiple times as justification for limiting patient access to medically necessary products.
Exactly. So it's important. I mean, you're going back to them for comment, but you didn't listen to them in the first place. Do you know what an SSRI is?
I have been advised.
Do you know how long it takes for one to take effect?
Not personally, but I've been advised.
About 2 to 4 weeks. And yet there's a standard here, but doesn't have an impact on someone's hospitalization with 7 days. It can be disregarded. Do you know that according to the National Alliance on Mental Illness, that seniors who die by suicide, 20% of them do it the day of their doctor's appointment, 40% the week of their doctor's appointment, and 70% the month of their doctor's appointment? The psychiatrists and their patients know that not all medications are created equal. Each one is in a different therapeutic, within a therapeutic class, have different molecular makeups, different side effects, different drug-drug interactions. They impact a person's brain in unique ways, which is why physicians and patients with serious mental illness often try different therapies until they find the right one that works. If you restrict access to these drugs, you restrict the treatment of mental illness. You impact increasing hospital stays. You raise suicide rates among a population that has an increased suicide rate once people reach 65. And you restrict and you forbid the use of life-saving drugs. On behalf of the mental health community, I urge CMS to reconsider, because senior citizens with schizophrenia, bipolar illness, or depression, this is a matter of life and death. So I want to ask you, will you commit to removing this unscientific, callous, and anti-medical decision that will lead to harm for seniors with mental illness?
Sir, I will commit to making sure that our policy is right for patients.
Sir, you are not a physician. You are the people's worst fears. You have no background, no education, no training, and it sounds like the people in this panel are not practicing physicians either and not psychiatrists. You are practicing medicine without a license. This cannot stand for people who are at high risk for depression and suicide and mental illness. I urge you to go back and remove this rule. Thank you. I yield back.
Chair thanks the gentleman. Now recognize, without objection, so ordered. Chair now recognize the gentlelady from Virgin Island, Dr. Christensen, for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Mr. Blum. I have a similar question to begin with. We've had many issues with CMS over end-stage renal disease patients and the regs that have been changed over the years. Were there any transplant physicians who served on the panel?
I don't believe so, but again, CMS proposed these changes in an open, transparent way. We walked through in very detailed our analysis, and we welcome feedback, we welcome disagreement to ensure that we get the policy right.
Well, given the risks to this vulnerable population, which make up a large part of the CMS covered, especially Medicare covered population, if they do not receive the appropriate immunosuppressive medication, doesn't CMS think it is important for a transplant physician who has experience treating patients with variant organ transplants to weigh in on how clinical practice guidelines should be interpreted?
We agree that CMS should do everything possible to make sure that patients receive the drugs prescribed to them that meet their clinical needs. I think it's important to recognize that we pay for about 140 drug classes. And while we have 6 protected, we don't hear the concerns regarding lack of kind of patient access. But however, we deeply recognize and deeply appreciate the concerns from patient groups, physicians, and we pledge to make sure that we listen, we understand, and to have our final policies best serve patients.
And we appreciate that. My experience is that clinical guidelines are an important reference for physicians to use to identify the treatments with the strongest evidence base, but that they are indeed a guide, and that decisions on immunosuppressive drug regimens and psychiatric medications must be tailored to the individual patient's needs, and this decision is best made by the transplant physician who really knows the medical history of the patient. I have a question that I also need to ask. CMS is proposing to make changes to the number of enhanced plans that can be offered by any one sponsor and to the number of contracts a sponsor can have in a bid region. I want to ask about this proposed requirement. I've seen one industry-sponsored study that says 7 million beneficiaries will be affected. A letter by the chairman notes that more than 8 million will be affected. Another industry-sponsored study cites 14 million people who will be affected. The number seems to be growing like Pinocchio's nose. On the other hand, organizations representing Medicare beneficiaries are strongly supportive of the proposed two-plan requirement. They believe it strengthens the program for beneficiaries, making choices more meaningful and making sure plans aren't gaming the system. So I'd like to provide you with the opportunity to discuss these proposals. My first question is, why did CMS believe it was important to address these issues and rationalize the number of plans that can be offered in an area? Was the agency seeing gaming?
Well, I think one game that we have seen right now, or that the program is now experiencing, is that some plan sponsors offer what they call enhanced coverage. That's actually coverage far cheaper than their basic benefit. And that's a strategy to select healthier beneficiaries to lower cost plans. Now, that may be good for the program, but on the other hand, what happens is that the low-income beneficiaries who are auto-assigned to that higher premium plan, the program pays the full premium cost. That costs the government, not saves the government. So we need to take a balanced look at how plan structures are being offered to ensure they best serve beneficiaries, they are not confusing, but they also lower total program costs.
Let me try to get in a couple. Thank you for that clarification. Could you comment on how the federal government, taxpayers, and plans, well, I guess you did, with dual eligible beneficiaries are paying more than they should because of the way the plan sponsors are offering multiple plans in that area? Did that pretty much address that question?
Well, I think beneficiaries, dual eligible beneficiaries, pay the same copayment. They're fixed in statute, but the Medicare program pays just about the complete cost of those drugs, not based upon a set fee schedule, but based upon the prices negotiated by the Part D plans. We want to make sure that we're paying the right, correct, fair rate on an apples-to-apples basis with our Part D plans.
Some have asserted this proposal will hurt dual eligible beneficiaries in the basic plans, but I interpret it exactly oppositely. Some enhanced plans that dual eligibles are not enrolled in may be consolidated with other plans, but dual eligible will benefit from lower costs in the basic plans that they enroll in. If I could just get an answer to that, is that correct?
Well, I think we want to make sure that when plans provide what's called enhanced coverage, that it's more generous than their basic plan offerings. One, to beneficiaries clearly understand what it means to sign up for coverage that's enhanced, but also to make sure that when the program is paying the complete cost of full premium, that we're not paying more than what we should if the plan structures were more consistent.
Thank you, Mr. Chairman, for allowing the answer.
Sure, thanks to the gentlelady, and now recognize the gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate that. Let me start off by saying that I'm concerned when you keep saying, you know, you can provide us with the legal staff's memorandum. This appears to be a major controversy as to whether or not these changes are legal, and most of the folks up here believe that it's not legal, particularly when it's so large a change. And I will have to tell you, this is what happens when one agency goes rogue. It wasn't yours, but you know, I dealt with the Solyndra situation, as many people up here did, and General Counsel there did not give good legal advice, in my opinion. They gave bad legal advice. The agency acted on it, and I think they violated the law not once but about 3 times. And that was my opinion after reviewing all of the documents involved and all the opinions involved, is they got bad counsel. So I'm going to ask you to get a second opinion after you provide us with what you've already got from your legal counsel. I'm going to ask that perhaps you look at getting a second opinion, because this is a very serious matter, and it appears that the legality is in serious question. Now, that being said, I have a little bit different tact, because last year, based on conditions in my district, I asked you all to do something, and that was to take care of our pharmacies. And I have recently had a conversation with one of my pharmacists who is willing to accept the price negotiated in the region. You know, just let me be able to provide my customers with the drug that they need or the drugs that they need. And he's been told no. And so when you say to us today that you're getting a lot of complaints, I understand that. Now, my question is, last year I wrote a letter, and I'm going to write you another letter thanking you all for taking care of the community pharmacies and saying, hey, if you meet the price, you can do it, because I represented Mountainous District May not be the big mountains they have in the West, but in the East, we've got some pretty good mountains in Southwest Virginia. And so if you don't have a preferred pharmacy, you might be in the same county, but you might not be in an area where my people can get there easily, particularly if we happen to have 20 inches of snow on the ground. It's going to be even more difficult to travel those 10, 20, 30 miles that may pile up to get to the next pharmacy that's on the list. And so I do appreciate what you all did in that regard. Question becomes whether or not you have the legal basis to do it. Now, under your theory, with what you're changing in this rule, and of course it's not the whole 800 or 700 some pages, and I do have serious questions about the rest of it, you're trying to take care of that situation. You're trying to make it so that my constituent can go to the pharmacy down the street instead of having to drive around the mountain to the next pharmacy over. Isn't that correct?
So I think a couple things. We want to make sure that we are proposing these changes in an open and transparent way. And so one of the benefits is that going through the notice and comment process is that we get the best legal advice, not just from our lawyers, but from the Congress, from outside stakeholders. And so to your first point about getting a second opinion, that's precisely why we chose to go through the notice and comment process. To your second question regarding the pharmacist protections, we believe that Part D plans should be able to offer tiered pharmacy networks. We see evidence that they do reduce costs for the program for beneficiaries, but we have two principles. Principle one is that beneficiaries need to benefit from those tiered pharmacy networks. So it can't just be the plan sponsor that benefits, but it has to benefit both the beneficiaries and the taxpayers. And we agree that that tiered pharmacy networks need to be fair, not just to the plan, not to the beneficiary, but to the community pharmacists. And so we have a hard time seeing the data evidence that we're seeing today, that the evidence for cost savings is mixed, and telling community pharmacies, well, they can't participate with major Part D plans. We want those tiered pharmacy networks to be fair. We want to make sure that beneficiaries see clear savings, but we agree that preferred pharmacy tools can be a good tool for the Part D program if structured correctly.
And here's the concern you're hearing today. Look, I think if you're fair to the beneficiaries, and I want fairness as well, if you're fair to the beneficiaries, then you are being fair to the community pharmacists, because in most cases, particularly in the rural areas, the folks know their pharmacist, they want to go to that pharmacist, and they go to somebody who's close by, and they want to make sure they don't have to drive around the mountain to get to the other side of the mountain in order to get their drugs, because it may not look like much on a map, but it's a big deal when you're having to drive that. But I have to say, you know, Mr. Shimkus was right earlier when he said the whole idea is if you don't have the authority, it doesn't matter how much fairness you want, you need to bring that to us, and you need to say we need a bill to make this fair. And if what I need to do to take care of my people is to introduce a bill, then I will do that. But let's make sure that we don't have the Constitution being set aside because it's inconvenient. I yield back.
Chair, thanks, gentlemen. Now I recognize the gentlelady from California, Ms. Capps, 5 minutes for questions.
Thank you, Mr. Chairman, and Deputy Administrator Bloom, thank you for your testimony today. I believe this proposed rule has some serious problems, but it also includes some important steps forward to ensure that future CMS decisions are based on the best data available. But today's hearing shows that it's important for us to be cautious as we evaluate ways to make this program more sustainable and efficient. One area that I'd like to add my voice of concern is in the proposal to eliminate some of the protected classes of prescription drug coverage. You know, I've been a public health nurse for too many years in my community, and I understand that access to the right treatment and I have grave concerns that as this rule is proposed, it could put that in jeopardy. This is especially important as many of the ailments that would lose this status are such common comorbidities, affecting perhaps many more individuals than we might think. And while I have concerns about access for vulnerable populations due to that part of the rule, I do want to applaud the agency for another change that will also have an important impact for improving care for patients, and that's the enhanced eligibility criteria for Part D medication therapy management, the MTM program. I welcome CMS's recognition of the importance of MTM that it plays in increasing medication adherence, improving health outcomes, and reducing overall program costs. Specifically, the proposed rule would lower the threshold for beneficiary eligibility the specific benefits that you envision this expansion will deliver to beneficiaries as well as to the Part D program, just so we get that on the record.
Well, one of the things that we know is that there are greater opportunities to assist beneficiaries, to ensure they stay compliant, to help manage polypharmacy regimes. Our team sees growing evidence that MTM programs can help to improve drug compliance, can lower overall costs of the program. We agree.
There have been some concerns about the policies in this and other proposed rules. Maybe it's lack of understanding, maybe it's just the complexities of the issues. But one of the main concerns we hear from supporters and opponents of changes proposed by CMS is that the data is not accurate. The proposed rule we are discussing today seems to get at some of those data discrepancies by requiring uniform standards for reporting negotiated drug prices across Part D sponsors. But I know that some groups are concerned that this could interfere with negotiations regarding drug prices with pharmaceutical manufacturers. It's a very complicated arena. But would you now expand on CMS's intent for this particular aspect of the proposed rule? What is the goal of this portion of the rule, and how do you think this is going to affect price negotiations, which, after all, is the bottom line?
Well, I think a couple things, Congresswoman. The Part D benefit is not a purely capitated program where CMS simply pays a premium to plans and lets the plans negotiate prices. There are other payment mechanisms built within the program. There's risk corridors, reinsurance, catastrophic coverage, the fact that for many low-income beneficiaries, dual eligibles, the program pays just about the entire cost of the drug bill. Now, we have no interest or no policy desire to interfere with the negotiations between Part D drug plans and pharmaceutical manufacturers, but we believe that those prices should be reported in a consistent way to make sure the program is paying fairly. And if the Part D plan is benefiting from the lower negotiated price, and given the large size of the premium costs, the cost sharing, the catastrophic coverage, the reinsurance, the risk corridor, that those prices should be paid, should be reported in a consistent way to ensure those discounts not just get retained by plans, but get passed on to beneficiaries and to the taxpayers that are funding the vast majority of the program costs.
Chair thanks gentlelady. Now I recognize gentlelady from North Carolina, Mrs. Elmers, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Mr. Blum, for being with us today. Mr. Blum, I think it's important that you know that over 500,000 seniors in North Carolina will be affected by these proposed rules, and I just want to start off by stating that fact. I am a little concerned with the interpretation that CMS has on not interfering or arbitrating or mediating between pharmaceutical companies and manufacturers. You're basically coming in and saying, what we're going to do is take over and dictate. Is that not essentially what you're doing?
I don't see any desire or attempt for us to dictate the negotiations prices between Part D plans and providers, manufacturers. We believe in private plan competition. We believe in choice, but that choice that's fair to beneficiaries and fair to the taxpayer.
Okay, and you've stated that, and you're basically reiterating what I said, but essentially what you're saying is you're going to come in and control the situation as a whole, kind of as a whole umbrella effect of control.
That's not what I said, Congresswoman. What I said is that we get pulled into disagreements between plans, pharmacies, other entities, and so our view is this clarification helps to strengthen the non-interference, to describe precisely how we interpret it on a day-to-day basis, but from a day-to-day basis, CMS continuously gets pulled into disputes.
Well, let's move on. Let's move on. The CMS rule proposed that prescription drug plans are limited to offering only one standard benefit and one enhanced benefit. Is this correct?
That is correct.
So essentially 50% of the plans that are available now will be decreased and eliminated.
I think a couple clarifications. First is this is a continuation and a continuous pathway for us to reduce the number of So we need to be concerned regarding the comments and the criticisms coming to us regarding this change, but we also have to look on the past 4 or 5 years to really make a complete judgment regarding this change, proposed change.
Okay, well, there again, to your point that you're making, or you're basically justifying the reasoning behind eliminating, as you pointed, only 2% of these patients receive the benefit from what is being eliminated, correct?
We are, I'm trying to give the justification to CMS's proposal. This is still in comment, and we have made no final decision.
And this is from a perspective of trying to save dollars in healthcare, is that correct?
I think our total estimates of the proposed change complete is that it's an overall savings, small but overall savings, and we're also trying to make the benefit work better for our beneficiaries.
Do you realize, though, that the changes that are being made to Medicare Part D will then actually increase the spending in Medicare Part A and Part B, because many times these patients will then be re-hospitalized, sent to the hospital for care. You cited in part of your justification at the beginning the vulnerabilities, one of which has to do with the protected classes of drugs. Patient body that receives those medications. That is an ongoing issue. Have you ever been to a nursing home before?
Yes, I have. And also, we understand that the nursing home industry is also very concerned regarding the high rate of use and the high degree of variability and antipsychotic use.
Okay, so to that point, would it not be more efficient then to go to the source? You cited overprescribing of medications. Wouldn't it make more sense to narrow down who it is that's prescribing drugs, overprescribing drugs, than it would be to eliminate the entire program?
Well, I think we have, Congresswoman, we've been worked very closely with the nursing home industry.
I only have one more moment, because it's not the nursing home that prescribes the drug, it is the physicians that prescribe the drugs. So that I want to make that clarification. In relation to the potential impact on seniors because of any willingness provider provision, staff of the Energy and Commerce Committee spoke with the Office of the Actuary, who told them, quote, anytime you make a network wider, costs go up. Can you respond to that? Because you just told me that this is an effort at decreasing cost.
We agree that pharmacy networks, I agree that pharmacy networks have the potential to lower costs for the program for beneficiaries. In our current program today, we see strong evidence that pharmacy networks do reduce costs. We also see evidence that some pharmacy networks in their current forms don't lead to cost savings for our beneficiaries and for the program.
So you are basically, what you are saying is a direct, complete,
what I'm saying is that
opposite opinion of the Office of the Actuary.
What I'm saying is that we believe that pharmacy networks, if structured correctly, made clear to beneficiaries the pros and cons to preferred pharmacy networks versus not. They do reduce costs, but the data right now shows that some pharmacy networks in their current forms don't reduce costs for beneficiaries. Our goal is to make sure that pharmacy networks, preferred pharmacy networks, work well for beneficiaries, but also work well for.
Thank you. I have gone way over my time, so I appreciate.
Chair, thanks, gentlelady. Now I recognize gentlelady from Florida, Ms. Castor, 5 minutes for question.
Well, I want to thank you, Chairman Pitts, for calling this oversight hearing for Medicare Part D, and thank Mr. Blum, who's here from the Center for Medicare and Medicaid Services, and thank everyone at CMS for working to improve Medicare Part D, helping to simplify it for beneficiaries, make benefits more meaningful, and cost-effective for everyone. But it has to be balanced by science, and I think that many of the many advocates for beneficiaries and those who have chronic illnesses and other sicknesses have very valid points about the protected class policy. So I want to make sure everyone's aware. This is a proposed rule. This is what CMS has proposed in January, correct?
Correct.
And there is an open comment period where you can receive comments from people, family members, pharmacists. Is that correct?
That is correct, Congresswoman, and we pledge to meet with all stakeholders on this issue to understand comments and concerns, and this is proposed, and we pledge to talk to clinicians, beneficiary groups to ensure that we get the policy right.
And the comment period is open until when?
I believe March 10th, March 14th.
Okay. Mr. Blum, many private insurance plans steer patients toward preferred pharmacy networks and mail order pharmacies in an attempt to lower costs. But CMS has found that total drug costs were not consistently lower in preferred pharmacy networks. And in fact, the retail pharmacies in the non-preferred network were actually offering savings to the Medicare Trust Fund through discounted generics at prices below those offered by pharmacies with preferred cost sharing. And I hope you've reviewed the research done by the National Community Pharmacists Association. The community pharmacists chose one commonly purchased prescription drug plan and entered in the Medicare Plan Finder 4 of the most frequently prescribed drugs: the generic version of Lipitor, the generic version of Plavix, Diovan, and Nexium. The costs were then compared between preferred, mail order, and non-preferred pharmacies in 9 cities across the country. And according to the analysis, I think it's quite surprising, 89% of the time preferred pharmacy costs to Medicare were higher than those of non-preferred pharmacies. And 100% of the time, mail order costs to Medicare exceeded those of non-preferred pharmacies. Now, this is really counterintuitive to how you think it would work. How can Medicare be paying more for mail order and more for drugs at preferred pharmacies? Medicare is supposed to be benefiting from competition here that will bring prices down. And it's troubling that plans are offering little to no savings in aggregate in their preferred pharmacy pricing, particularly in mail order for generic drugs. So instead of passing on lower costs available through economies of scale or steeper discounts, a few sponsors are actually charging the program higher prices. So preferred networks and mail order pharmacies should save the patient and the Medicare program money, I would think. So I'd like to ask you first, is the situation I described where mail order and preferred pharmacies are costing Medicare more than community pharmacies similar to what CMS found in your analysis of Part D?
Thank you for the question. First, to clarify, the comment period for the proposed rule closes March 7th. I apologize for not giving the accurate answer. To your question regarding preferred pharmacy networks, I think the reason why CMS proposed this change was that we saw similar data results. That you look at the actual cost of the drug being paid by the program, being paid by the beneficiary through cost sharing. There's not a consistent pattern that preferred pharmacy networks mail order lead to consistent lower prices for beneficiaries for the program. And we want to make sure that our Part D plans have all the cost containment tools that they can use to lower costs, benefit beneficiaries, benefit taxpayers. But when the program is permitting plans to restrict some pharmacies to not participate within their networks. We believe the principle should be that we need to demonstrate there is savings to our beneficiaries, to our taxpayers. So we embrace preferred pharmacy networks so long as they're fair to beneficiaries, they're fair to pharmacists, and they're fair to the taxpayers that fund the vast majority of the cost of the program.
So you would agree that it is inconsistent with the Part D law that preferred networks would cost Medicare more money?
I think the intent of the program is to ensure that Part D plans have tools to lower costs, not just the premium, but cost sharing, reinsurance payments, risk corridor payments, and that should be the principle that the Medicare program follows.
Thank you very much, Amber.
Chair, thanks, gentlelady. Now I ask for consent to submit for the record 3 letters, one from the National Association of Chain Drugstores, one from the American Society of Transplantation, and one from the Association of Mature American Citizens. Without objection, so ordered. Now the chair recognizes gentleman from New Jersey, Mr. Lance, 5 minutes for questions.
Thank you, Mr. Chairman. Good morning to you, Mr. Blum. I'll be concentrating on what I believe is an overreach by the department, and I understand when the law was written there was a debate whether there should be negotiations involving the federal government, but as I read the law, that was clearly decided in the statutory law, and I'm deeply concerned at what I believe is the illegal reading of the law by the agency. And my concerns go not only to this situation, but to several other situations where the administration has unilaterally delayed the ACA. I think the administration should have come to us in Congress for statutory change. Recess appointments, argued before the Supreme Court several weeks ago. I believe the Supreme Court will rule those recess appointments were unconstitutional. EPA regulation under the Clean Air Act, argued before the Supreme Court earlier this week. Now, that's not your purview, any of those matters, I understand that, but you are here this morning regarding the topic under discussion. There's a legitimate debate in this country whether or not there should be negotiations by HHS. I understand that. The non-interference provision is, in my judgment, unambiguous that that is not the right or the responsibility of HHS. It does not permit negotiations between Part D sponsors and pharmacies. And as I understand what was statutorily created, Senator Grassley stated, for example, that the non-interference provision is at the heart of the bill's structure for delivering prescription drug coverage through market competition that gets a good deal for consumers rather than through price fixing by the CMS bureaucracy. In the conference report at the time the legislation became law, this is a direct quote, "In order to promote competition, the Secretary is prohibited from interfering with the negotiations between drug manufacturers and pharmacies and PDP sponsors." Between drug manufacturers and pharmacies and PDP sponsors. And yet, as I read what has occurred in this proposed rule, prohibits only HHS involvement in negotiations between drug manufacturers and pharmacies, and between drug manufacturers and PDP sponsors, but under the rule not prohibiting HHS involvement in negotiations between pharmacies and PDP sponsors. Am I accurate in that?
I think we have clarified how we interpret the non-interference Part D program should interfere with price negotiations. I said previously, oftentimes Part D plans, pharmacists bring into contract disputes. We felt that
Chevron doctrine, and undoubtedly this will be litigated if the rules are finalized. And I would urge the administration, based upon sound principles of law, to reconsider this matter, and if a change is required, as is true in so many areas, the ACA, recess appointments, EPA regulations, I urge the President and the administration to come before Congress to seek statutory change. Thank you, Mr. Chairman.
Chair, thanks to the gentleman. Now recognize the gentleman from Maryland, Mr. Sarbanes, 5 minutes for questions.
Thank you, Mr. Chairman. Thank you, Mr. Blum, for being here. I think it's an important undertaking what CMS is doing. I think it's a fair expectation on the part of the taxpayers and the beneficiaries that periodically you kick the tires on the program, even if it's working very well, and we're all happy with the track record. I mean, when this was first rolled out, there were problems. Democrats who were initially concerned about the program, I think, stepped up to try to improve it, and we now have a program that works well and is respected by its beneficiaries. So that doesn't mean that you don't come along every so often and try to make it better, which is what you said. So we ought to be going through this exercise, and I endorse the process that you've undertaken. The proposed rule covers a lot of different areas, as you've indicated. I share some of the concerns you've heard with respect to removing the protected class for certain categories of drugs. And as you know, there's a broad coalition that has expressed those concerns, and I encourage the agency to pay careful attention to that. In terms of the requirement to reduce the number of plan offerings, I agree with you. I think that's an important step to consider. I think you're right to point to the alarm that existed the last time you did something like this, and the track record now shows that it's been an improvement overall. And there's still potential for a lot of confusion on the part of seniors and beneficiaries when they look at the plan offerings. So as long as we're not diminishing the quality of the options that are available across the board, I think that that's a reasonable change to pursue. I share, and you've seen this on both sides of the aisle, concerns on the part of independent and community pharmacists that they're not getting the full benefit and access to some of these preferred networks and so forth. And that's really something that the rule is trying to address. The Medicare program, the Part D program, is not permitted to negotiate with drug manufacturers, correct?
correct.
But you reimburse plans that are themselves negotiating with those drug manufacturers.
Correct. Part D plans negotiate the formularies and negotiate the prices with manufacturers. It's not true that CMS simply pays a fixed premium to Part D plans. We pay many other separate payments that are based upon the actual prices being negotiated. We don't plan or don't want to interfere in those negotiations, but the 2003 law that was legislated created many separate payment mechanisms that the program pays Part D plans, And for many beneficiaries, we're essentially a cost-based reimbursement, particularly for the dual-eligible beneficiaries that receive continuity of coverage.
It's certainly fair for the program to expect that if the plans are securing discounts, that some of that benefit would come back to the program and to the taxpayers. If the program was not doing the reimbursement, if the patient was paying directly to a plan that originally cost $100 for a drug, and the plan was paying $75 and getting a $25 markup, but then was able to go negotiate and get that for $50, there would certainly be an outcry on the part of the consumer if none of that savings was being passed through. I think the transparency that the program is demanding pricing is and how it works is to get to the notion that taxpayers also have a rightful expectation that if there are significant discounts being earned by the plans relative to the manufacturers, that some of the benefit of that ought to come back to the program. And that interest on your part in transparency does not translate into interference or trying to negotiate directly with manufacturers, anything else. That's just basic fair transparency. Is that not right?
Correct, and we believe that competition has served the Part D program well in the past 10 years. At the same time, we believe that prices reported to the program for purposes of paying cost-sharing assistance or other, kind of payment mechanisms need to be reported in a consistent way to ensure that competition is fair, to ensure that both beneficiaries and taxpayers benefit from that competition.
Thank you.
Chair, thanks, gentlemen. Now recognize the gentleman from Louisiana, Dr. Cassidy. 5 minutes for question.
Hey, Mr. Bloom.
How are you?
You always know your stuff, man. I don't always agree with you, but you know your stuff, so thank you. Let's just put it on the table. In your testimony, you mentioned that concerns recent changes to the MA program will result in lower enrollment, higher cost appear unfounded. But let's be honest. Only a small fraction of the scheduled cuts have come into being, and indeed, the cuts that were already scheduled were papered over by large grants from CMS. I would note GAO questioned the legality of those demonstration projects. A cynic would say they were being papered over prior to the last presidential campaign, but far be it from me to accuse the administration of politics. So given that, I mean, you see no basis that these cuts going forward could have an impact on the care that patients are receiving?
So before the Affordable Care Act was signed into law, Medicare paid on average about 13 to 14% more than the same cost for the traditional fee-for-service program. Today we are paying roughly about 103% of costs on average compared to the fee-for-service program. So a dramatic decrease in the total costs that the program paid private plans. That includes the costs to our quality bonus demonstration. During that time period of dramatically lower
But I'm not to interrupt, we have limited time, I don't mean to be rude. Going forward, there are further cuts. I think I see JP Morgan says that payments will be cut at least 4% in 2015, which is more than you suggest, but nonetheless. So the cuts begin to accelerate.
So we estimate that the proposed change that CMS put forward last week for the Medicare Advantage plans, on average, will be roughly the same change that was finalized for 2014, the current year.
But without the demonstration projects?
Net. So apples to apples comparison. In 2014, we're on % growth projection.
But let me ask you, those cuts are in addition to the previous cuts. So you had cuts, you have more cuts, you have more cuts in 16 and more cuts in 17. At some point, the cumulative effect, that was saying 3% this year is not going to result in any worse harm than 3% last year, ignores the fact that you had 3% last year.
So every year CMS phases in parts of the Affordable Care Act changes. Every year we hear that plans will pull out, benefits will be cut.
No, now you're dodging the question. The fact is that you're having accumulation of cuts. So sure, we can speak about rhetoric and about how, you give grants and somehow it doesn't happen. but there's 3%, there's 3%, and it accelerates. And to say that that's not going to, I mean, are you really maintaining that these cuts are going to eventually have no effect?
I think
yes or no.
What we are saying is, what I believe is that the past 5 years we've seen.
Never mind, that's fine. I don't mean to be rude, but this is clearly a talking point. I don't mean to be rude, but I'm not getting a yes or no. I'm sorry. Next, one of your things is that you're going to require physicians to be enrolled in Part D in order to participate. Now, I'm a doc. I get so sick of bureaucrats telling me how to run my show. There's so many things that already are looking at me. I mean, physicians must be one of the most scrutinized people in terms of bureaucracy staring at them. Why are we going to kick out docs from the ability to prescribe if they're not a Medicare provider?
Well, I think we have, I testified to the Senate Homeland Security Committee based upon reports from the IG that found that the program was paying for prescriptions written by physicians. We think it's appropriate for us to have the same standard.
Now stop, if I may. There are other ways to weed out unlicensed physicians. Do we have to say, okay, if you are licensed, you cannot work for a nursing home in an underserved area. You're not going to be able to work for them because somebody without a license should be kicked out anyway.
Well, that's the situation that we have today. That's the rules that we have today, that we rely on state pharmacy licensure, and that hasn't worked.
Now, I will say that that doesn't mean that now we're going to use as a surrogate for that not working another set of regulations. As speaking for my fellow physicians who are groaning under the burden of paperwork laid upon them by CMS and thinking about getting out of the system because they're so sick of it, this threatens the seniors' access to physician care because CMS doesn't understand that one more piece of paperwork is just enough to make me retire to Florida.
Well, we understand the burden. But
if you do, you're not operationally understanding it.
Well, our principle is to make sure that prescribers who are writing scripts pay for the Part D program are licensed.
I don't see the rationale for that beyond you don't think other laws are being implemented. It's being enforced. It seems better to enforce those other laws than add on more regulation.
Well, those are state laws, and I think we feel that we have a responsibility to ensure that the taxpayers that fund the vast majority of costs of the Part D program are paying for prescriptions that are written by legitimate physicians.
With that defense of further centralization of health care into the federal government, I yield back.
Chair, thanks, gentlemen. Now recognize gentleman from Kentucky, Mr. Guthrie, 5 minutes.
Thank you, Mr. Bloom. Thank you for Mr. Shimkus you had. If I heard correctly, which I think I did because I wrote it down, he quoted a 2010 position that CMS had that would not have allowed this rule to go forward. And then you said, and I quote, reinterpreted the law to allow this rule to go forward. You also said that you understand the legal concerns that we have, not in that exchange, but no, you understand the legal concerns that we have, which I say you understand that the basis is probably questionable, or else you wouldn't understand our concerns if you didn't understand how we could question that. And you said that you've been pulled in by other groups to get involved in negotiations. You had to come up with this rule because other groups want you to be involved. And I hear from people all the time in my district, veterans, other things, that they're in bad situations. And I just have to say to them, I wish I could help you, but the law is the law. And it's my job to change the law and fix the law to help you in that situation, but I can't just go reinterpret the law. And that's what you said. And I think all of my colleagues, whether Republican or Democrat, House or Senate, should be really concerned of what you said today, that there could be a position of CMS, you want to do something different, so you go back and reinterpret the law on a questionable basis. I just think that I just want to put out that's what was said, and I'll give you a chance to respond to that if you want to do so, or I can go into my questions.
Well, I think a couple things. As I said during my opening statement, the Part D program has many vulnerabilities, and we did a comprehensive review based upon the policy concerns that come to us from members of Congress, stakeholders, partners, based upon our own operational experience. We chose to propose changes, to talk about our principles, to testify here today, to discuss the vulnerabilities that we see.
But did you have to reinterpret the law to go
We
forward on
want
this?
to invite comment. We want to invite conversation that we don't believe the status quo for the Part D program is perfect. There are vulnerabilities. We have to accept that. We have to accept the program is spending $70 billion, the fastest projected
Let me
program.
finish. I only have I'm going to get to a question, but if you have if all of that is true, and if we accept all of that, that still doesn't mean you can just do it without the legislative authority.
And that's
to do so.
precisely,
All of my
why,
colleagues
that's
would be-
precisely why we go through notice and comment period. We want to invite perspectives. We want to testify before this committee to explain our rationale, to hear disagreement.
But but the legal side, I'm not just saying whether the rule is correct or not.
During the
legal
comment
side.
process, many stakeholders submit legal opinions. Law firms submit comments to us, whether we're right or
I didn't
we're
want to get to
wrong.
my but you had to reinterpret the law to get to where you were. That was your quote.
I would call it a clarification, sir.
Okay. Well, you said reinterpret. One complaint I don't hear from my constituents is Medicare Part D. I just don't hear from them on Medicare Part D as a problem moving forward. And you did say in your opening statement
I would
that
invite you to look at the complaints.
I'm going to look to your complaints and see, but I don't. When I go to town hall meetings, nobody stands up and says I don't like my drug plan. But so one of the things you said, you support competition as long as seniors understand, and you know that. Imagine going into a superstore and saying, "Here's the aisle, limited choices for people that are 65 and older, and here's the rest of the superstore for everybody else." And you know, it just says, you know, they do understand, and it's the minimum report says up to 50% of Part D plan choices may be eliminated or materially changed during 2015 or 2016 based on provisions in the rules. So some of my constituents will have plans that they chose, plans that they like, and if they like what they have, they can keep it, as we've heard. And I know that when constituents under the ACA plans were changing, people were just saying, well, they were paying for something they shouldn't have paid for because it wasn't worthy insurance. I've heard that even in this committee. And obviously, so it's just assuming people don't understand what they're buying. And I don't think that's the case. I think people are far more sophisticated and smarter than maybe what those kind of comments give them credit for. And so what do I tell my constituents if they can't get plans because they're limited? You say it's only 2%, but that's 2%.
I think a couple of things. One is we want to make sure that we are incorporating to our final policies the views from the beneficiary communities, beneficiary stakeholders. What we hear from the beneficiary community is that the benefit is confusing. We see from the academic literature that beneficiaries would have the opportunity to reduce their out-of-pocket costs dramatically by changing plans. We want beneficiaries each year to take a critical look at their benefit offerings because we know that many beneficiaries will be able to save, reduce their out-of-pocket costs. That's why we have private plan choices. We want competition. We want beneficiaries to evaluate and be able to understand the benefits for different plan options. But we know that most beneficiaries year to year don't change plans, even though they could benefit dramatically by changing plans. Part of the reason that we hear from the beneficiary community, and again we invite this public conversation, is the benefit is confusing. We see plans cherry-picking the healthiest beneficiaries, raising costs for the rest of the program. But we will respectfully review and carefully review comments sent to us to make sure that we are fostering competition, but in a way that helps beneficiaries choose the best possible plan, but also make sure the taxpayers don't overspend. I would hope the Congress would want us to manage the Part D budget in the most prudent way.
Well, thanks. I do appreciate you coming today. Appreciate it. Yield back.
Chair, thanks, gentlemen. Now recognize the gentleman from Georgia, Dr. Gangry. 5 minutes for questions.
Mr. Bloom, you've been with CMS since 2009, is that correct?
Correct.
You've been in this current position, #2 guy, for what, about a year?
Roughly speaking, yes.
I certainly can understand a new coach coming in wanting to do something kind of drastic, but quite honestly, and I do commend you on the transparency aspect of this proposed rule, but I think the rule is boneheaded. In fact, Bill O'Reilly would probably call it pinheaded. I would expect, since you've been around since 2009, that you know on, let's say, a 5-year average, the last 5 years, how many participants in Medicare Part D, the prescription drug plan, have reached the donut hole, what percentage on average over the past 5 years?
don't have the numbers in my head, but what is true is many fewer beneficiaries are hitting the donut hole because it's being closed.
Yeah, well, I suspect that number is pretty low. I'm surprised you don't have that. Maybe somebody behind you could whisper in your ear and tell you.
But I believe the numbers are roughly year to year. Well, and it changes year to year. Roughly 3 to 4 million Medicare beneficiaries hit the donut hole.
Yeah. Yeah.
Each year.
Well,
However, but
I would suggest that you're trying to kill a gnat by torching a village. You're trying to fix things that are not broken, and to do it, maybe the optics of closing the donut hole look great, and so you have to go back and say, well, we're going to look at these protected classes, and we're going to do something about that, and we're going to save money. So we can close the donut hole. And look, listen to these 6 drug classes: anti-neoplastics, that's cancer, ladies and gentlemen; anti-convulsants, maybe we ought to add marijuana to that; antiretrovirals, that's AIDS drugs; antipsychotics, antidepressants; anti-immunosuppressants. These are people that have had transplants, renal transplants. And if they don't get the drugs necessary, within 3 to 5 years, they can't pay for them, and all of a sudden they reject these transplants. I wish I could tell you that I was shocked at the egregiousness of this proposed rule and that this was all just a mistake, but that would be too kind. At this point, we must recognize the pattern of this administration attacking any health care program that empowers the free market, no matter the pain it causes beneficiaries. I personally, as a physician, find it reprehensible that the administration is so against any market-based system that they are willing to once again harm seniors to serve the purpose. Maryland said, every now and then you have to kick the tires to see if a program is working. Well, on the Affordable Care Act, every time you kick the tires, your foot goes through the sidewall. So maybe you're a little reluctant. So you kick the tires of a good program, and your foot comes bouncing right back in your face. And that's what's going on here. And let's be clear. This proposed rule will destroy the Part D program as we know it. It will limit our seniors' coverage options, and it will force higher premiums, unwarranted changes to a program where beneficiaries are overwhelmingly satisfied. It just doesn't make sense. Mr. Bloom, even as I disagree with the contents of the rule, I also question whether CMS, you guys, even have the legal authority to reinterpret the clear congressional intent in the Medicare Modernization Act of 2003. I was here. I was here when that was passed. The Energy and Commerce majority staff requested that CRS review the legality of your actions, and we requested a memo in response. The memo cites, and I'll just give you a little bit of it because I'm running out of time, a Supreme Court decision that interpreted a statute, a court should always turn first to one cardinal canon before all others, that a legislature says in a statute what it means, and it means in the statute what it says. Mr. Bloom, Congress has opined on this. Why does CMS feel the need to act at all when the law is crystal clear on this issue?
Well, I haven't seen the CRS report. I would welcome having a chance to look at it.
Well, Mr. Chairman, I will request unanimous consent that we make this report from the Congressional Research Service on the proposed interpretation of the non-interference provision under Medicare Part D as part of the permanent record.
Without objection,
let me just conclude. I am urging you, Mr. Bloom, to withdraw this rule. And I personally, as a member of this committee, am prepared, and I will also urge our leadership, fight with every tool available to repeal this rule legislatively if you guys do not heed the wishes of our seniors and the American people. I've gone over my time, and of course I'll yield back, Mr. Chairman.
Chair, thanks, gentlemen, and I'd like to ask the staff to provide a copy to the minority, please. Chair now recognizes gentleman from Florida, Mr. Bilirakis, 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate it very much. And again, I represent over 100,000 seniors in the Tampa Bay area, and they seem to be very pleased with Medicare Part D. And I'm along with Dr. Gingrey, if it ain't broke, don't fix it. Mr. Blum, specifically, I'm concerned about CMS's reinterpretation of the non-interference clause of the Medicare Part D statute. It was clearly written so that CMS would not interfere with the negotiations between drug manufacturers, pharmacies, and Part D sponsors. You may or may not know that I'm in a unique position here since my father, Congressman Mike Bilirakis, was the chairman of the subcommittee. And again, he remembers the intent of the law as written by him and his colleagues, and it was not to allow CMS to interfere in any of these negotiations. And I was in the legislature at the time in 2003, and I followed this as well, and that was my interpretation of the law, that the intent was for CMS not to interfere, but not to allow CMS to interfere again in the negotiations. You should know that, of course, you were I believe you were on Senator Baucus' staff at the time, so I'm sure you remember. So I'd like to ask you, Mr. Blum, are you telling me that the authors of the legislation, of course, including my father, are wrong when they say that they intended for CMS not to interfere in these negotiations?
So, going back to my days on the Senate Finance Committee, I worked with your father and his staff during the conference committee that produced the final Part D legislation. And so I understand well the intent of the Congress at the time. Senator Baucus, my former boss, and the team that he had, myself included, were directly involved in the drafting of the Part D legislation. So I understand well why Congress chose to put in place the non-interference clause. While we understand the disagreement, and it's clear from this hearing today, there is a disagreement. We propose the change with the interest to make the provision work better, to have it be stronger, to make it really clear when CMS will and won't get involved with contract disputes with Part D sponsors and pharmacies. We get asked frequently to get involved with those disputes. We wanted to kind of articulate to the public when won't CMS will try and broker beneficiary access issues or pharmacy network issues. We will thoroughly review, and I look forward to looking to the CRS document to understand our authority, to make sure that our legal team understands it, but as I said several times during this hearing, our intention is not to interfere with the price.
Thank you. And you understood the intent of the law then, and now you understand it as well.
Having served on the Finance Committee staff during the 2003 drafting, I understand the 2003 legislation
Thank you, sir, because I don't have a lot of time. I want to get on to the next question. Appreciate it. You justify some of the changes in the rule as a means to address prescription drug abuse. It seems to me that we could manage some of the prescription drug problem through the use of pharmacy lock, the lock-in program, where a single point of sale could provide more protection against the problem of doctor shopping, pharmacy shopping, and inappropriate drug therapies for high-risk beneficiaries. Pharmacy lock-in has been used successfully in state Medicaid, of course, as you know, and also with TRICARE and commercial insurance. Are you in support of pharmacy lock-in, sir?
I have testified on the record last summer to the Senate Homeland Security Committee that we believe lock-in provisions can help to reduce inappropriate prescribing, prescriber fraud. We have concluded that Congress would have to act to authorize us to allow pharmacy lock-in, but we believe that's a change that Congress should make.
So in other words, you agree with a pharmacy lock-in. Why isn't it in this particular rule?
We don't have the authority for that change, and I have testified that Congress would have to give us that authority.
Okay. I've introduced a bipartisan bill on this particular issue, but staff at CMS have not replied to requests from this committee for technical assistance on this bill. Today, would you commit to me, you personally, to review this legislation that I've offered? I've actually filed it. It's been
Absolutely.
about a few months. So I'd like to get your feedback with regard to this legislation. Would you personally commit to me that you will review that and respond to me?
Absolutely.
Okay, thank you very much. Appreciate that.
Chair, thanks, gentlemen. Chair, thanks, Mr. Blum, for spending 2.5 hours with the subcommittee this morning. We really appreciate your time and patience. We will send you additional questions. We ask that you please respond to those promptly. There are two things I want to highlight. Dr. Burgess' question was for the full and complete cost analysis that led to the rule, if you'd provide that, and Mr. Guthrie's question, the call sheets, the full complaint data that you referenced that you say show seniors don't like their Part D plans. Would you provide those to the committee?
To clarify the complaint data, 2013 CMS received over 30,000 complaints on various Part D issues. We have to protect beneficiary confidentiality, but we'll do our best to make sure that we can summarize that data in a way that will be helpful to this committee.
Redact the names and let us have it.
Go ahead.
Mr. Chairman, I think you can redact the names and let us have the information.
We'll
because
look
the
into it,
complaints
sir.
themselves will be significant.
Yeah, we'll look into it, sir.
Thank you, Mr. Chairman.
All right. Chair, thanks, gentlemen. We will now take a 5-minute recess as the second panel set up. Potty break. Oh, me.
Chairman. Hey, Dr. Karen. I just didn't know if you guys are okay if we move the markup briefing to 4:30 instead of 5.
I had to check. I think Frank has meetings and other things, so.
Okay.
Come
on, I'm trying to get you out here earlier.
Why would that get me out early? That makes me later.
No, 4:30 instead of 5.
I thought it was at 3.
No, I think it's at 4:30.
Oh, the notice it was at 5?
No, I'm just checking the 1 minutes. But
I
it
just
is a
learned this as
little
well. That's why I'm
blurry.
asking.
But at least it works. That's the
Oh, the
main
markup's
thing.
at 3.
As long as it works.
Okay.
Yep.
Our time of recess having expired, we'll go to our second panel. We have 3 witnesses. On our second panel today, we have Mr. Douglas Holtz-Eakin, President of the American Action Forum, Mr. Carl Schmid, Deputy Executive Director, the AIDS Institute, Mr. Joe Baker, President of the Medicare Rights Center. Thank you all for coming. You'll each have 5 minutes to summarize your testimony. Your written testimony will be placed in the record. Dr. Eakin, you're recognized for 5 minutes for your opening statement.
Well, thank you, Chairman Pitts and Ranking Member Pallone, members of the committee, for the privilege of being here today to discuss what I consider to be a crucial proposed rule from CMS. You have my written statement. Let me make just a few brief points at the outset. First, as has been discussed, the Part D program has a tremendous record of success. It has come in well below the projected budget costs, and I note with irony that Mr. Blum said one reason to do this rule is CBO is saying it's going to cost so much in the future, when it came in at $55 billion after my CBO projected it would cost $122 in 2012. It also has had stable beneficiary premiums. It has a very high level of beneficiary satisfaction. 85% of seniors are very happy with Part D. For those who are interested in the statistics on this, I'll point out 30,000 complaints is less than 0.1% of Medicare beneficiaries. So we got approval at 85, complaints at under 0.1% of 1%. And seniors have, in 2013, at least 23 choices in every plan area. And so that record of success is not an accident. If you think about how Part D works, the plans sit in the middle, and the plan sponsors, and they negotiate with the drug manufacturers discounts on their drugs on the basis of the volume of business they can deliver. And to do that, over here, they go out and offer different plans with different formularies, not to confuse seniors, but to attract more volume and get better deals over here. And they develop these preferred pharmacy networks with special provisions, again, by offering lower prices, they get more volume, they get more ability to negotiate over here with the drug manufacturers. That capacity to undertake these negotiations is at the heart of the success of Part D. And for Mr. Blum to suggest that by setting a savings standard, a minimum savings standard that you have to get in a preferred pharmacy network, that's a direct intervention in the price negotiation with those pharmacies. And to suggest that you offer to someone you've never negotiated with exactly the same deal you've given to someone you negotiated with, that's a direct intervention in the negotiations. I believe that the idea that this is not violating congressional intent with the non-interference clause is just transparently false. I mean, I was there at the birth of the Part D benefit, as were many in this committee. This is just flatly inconsistent with what Congress intended. I'm not a lawyer, so I don't know about the statutory authority, but the lawyers I've consulted with say they don't have the authority to do this. And for Mr. Blum to suggest this somehow strengthens the non-interference clause is just Orwellian doublespeak. And I'm deeply troubled by the fact that they would do this. The implications, I think, are very important. First, and this is your self-interest, if they do this in Part D, they don't need you anymore. Not this committee, not the full committee, not the House, not the Senate, not the Congress. They can do whatever they want with the Part D benefit. And I believe that's an inappropriate power for an administration to have. And it also hurt the program as a whole, because if you're a plan sponsor and you've got an administration that has the power to do whatever it wants without real consideration of the consequences, you're either not going to participate or you're going to charge a lot to participate, and that's going to hurt the seniors, which in the end are the focal point of the program. So I believe those provisions are ones that certainly cannot be rushed through in the next couple of weeks, shouldn't happen at all, and I'd urge the community to do everything in their power to stop them. The other features of the rule, there are many details in here, but limiting the number of plans harms the negotiations that they can deal with the drug manufacturers. As a result, there is no real way that CMS can claim to be monitoring savings in the program by looking at one half of this equation. That's incomplete and incorrect. And any support for this rule on that basis has to be questioned. They need to provide a lot better support, as in the cost analysis you mentioned. Some private estimates to suggest the limiting in choice, the limiting competition is going to raise plan bids by about 10%. That may not directly translate into 10% higher premiums for beneficiaries, but those 10% costs will go somewhere in the system. That's bad news for taxpayers, bad news for beneficiaries, or both, and we need to be concerned about that. There's no question. I think this leads to higher budget costs for a program that has consistently surprised on the downside. And, you know, we've had a lot of discussion. This is going to restrict some seniors' access to their doctors and or their particular pharmaceuticals, and those are steps in the wrong direction from the point of view of the program. I guess the last thing I'd close with is there's been a lot of discussion about seniors getting in the right plan. It's not as if there's no other way to do that. This is a terrible way to solve that problem. Mr. Blum runs a website called Medicare.gov with a plan finder. He might want to devote his efforts to improving that. Thank you.
Chair thanks, gentlemen. Now recognizes Mr. Smith for 5 minutes for opening statement.
Thank you. Good afternoon. The AIDS Institute is pleased to offer our views on CMS's proposed Medicare Part D rule. Since we believe aspects of the proposed rule would erode a patient's ability to obtain the medications that their providers prescribe, we are urging CMS to scrap the proposal to change the 6 protected classes. Frankly, just like many of you, we were rather surprised the Obama administration would propose such a rule, given its strong commitment to quality health care, including mental health, and to others living with illnesses and diseases. For people with HIV and so many other patients, new drug therapies have saved millions of lives and prolonged millions more. The advent of antiretroviral medications in the late 90s turned HIV from a near certain death to a more manageable disease if patients have access to quality care and medications. We know all medications are not the same, and each person reacts differently to a particular drug. Doctors and patients together make careful decisions about which therapies are most appropriate on a case-by-case basis. Some individuals may develop side effects to a particular drug, while another may need a therapy to avoid a harmful interaction for a drug being taken for another health condition. For people with HIV, drug resistance can occur, requiring them the ability to switch to another drug without interruption. It is for these reasons when Medicare Part D was first implemented, CMS determined that a minimum of only 2 drugs in the class, which is what the law requires, was simply not enough for certain patients, including those with HIV, mental illness, cancer, epilepsy, and those undergoing organ transplantation. The 6 protected classes was created so that patients could have access to all the drugs in these classes. For the past 10 years, Medicare Part D has been working for millions of seniors and people with disabilities, including over 100,000 people a year with HIV. As part of the Affordable Care Act, Congress even codified the 6 protected classes. We see no reason why the protected classes should be changed, and if they were, we would like to see more classes of drugs gain protected status, rather than reducing them so that more patients can gain access to the medications prescribed. As I commented earlier, we were shocked when we read the proposed rule. The Secretary used the authority granted to her under the ACA to develop criteria to alter the 6 protected classes, and at the same time proposed to eliminate 3 of them. One would think if the administration was contemplating any changes, the criteria for class review would be developed first with adequate public comment before it was applied. Instead, a very arbitrary criterion was developed in secret and then arbitrarily applied at the same time. Thankfully, the proposed rule continues the protections for antiretrovirals. That would not be the case for antidepressants and immunosuppressants in 2015 and antipsychotics in 2016 if the proposed rule was finalized. Frankly, we are worried. Who will be next access to all the medications they need through Medicare Part D? Because it is estimated that about half of people living with HIV experience mental illness or substance abuse, we are concerned that people with HIV who rely on antidepressants and antipsychotics will not be able to access their medications. We are also concerned that people with hepatitis, who we also advocate for, who undergo liver transplants, will not be able to access their immunosuppressants. Medicare Part D, including the 6 protected classes, is working. It is enabling the elderly and the disabled to access the medications their providers prescribe, and at the same time saving and prolonging countless lives. We see no reason to change the protected classes and urge the administration to withdraw this proposal. We are encouraged by CMS statements this morning that they are sensitive to and are carefully listening to our concerns. Hopefully, in the end, they will do the right thing for patients. Thank you.
Chair thanks, gentlemen. Now recognize Mr. Baker for 5 minutes for an opening statement.
Thank you, Chairman Pitts and Ranking Member Pallone thank you, Chairman Pitts and Ranking Member Pallone for the opportunity to testify today on the proposed rule for Medicare Advantage and Part D prescription drug plans. Excuse me. As you know, the Medicare Rights Center is a national nonprofit that works to ensure access to people with Medicare, both older adults and people with disabilities. We answer over 15,000 questions each year from beneficiaries, family caregivers, and professionals, and our online resources receive more than 1 million visits annually. I want to stress 3 key points today. First, we believe that each one reflected in this rule should be evaluated on its own merits, as opposed to supporting or rejecting the entire rule as a whole. We note that the comment period, as has been said, for the rule is still open, and all interested parties should submit comments and give CMS a chance to modify the rule based upon those comments. In this spirit, I'd like to talk about a couple provisions that we strongly support and others that we do oppose. Second, I think the rule reflects CMS's belief that increased oversight and monitoring is required to ensure that Medicare Advantage and Part D plans are adequately serving people with. In particular, we strongly support CMS's proposal to ensure meaningful differences among Part D plans by further consolidating plan options. On our helpline, we observe that older adults and people with offerings from the same plan sponsor reduces confusion and helps people better comparison shop. Further related to Part D, CMS acknowledges that Medicare Advantage plans with prescription drug coverage are not adequately coordinating beneficiary care with respect to drug denials. When a Part D drug is denied because it should be covered by Part A or B of the plan, CMS finds that some plans are not adequately informing beneficiaries that their drugs should be covered. This indicates that some plans are not living up to their promise to coordinate care efficiently for their members. To fix this, CMS appropriately suggests new requirements for plans to facilitate access to these medicines. Throughout the proposed rules, CMS demonstrates a commitment to enhancing transparency. For instance, increased transparency is at the heart of proposal concerning drug pricing fairness and accuracy with respect to preferred pharmacy. CMS also aims to make information about annual changes to Medicare Advantage and Part D plans more transparent through proposals to strengthen beneficiary notices ahead of and during the annual enrollment period. We support these proposals. Finally, CMS aims to increase oversight and monitoring of prescribing providers to address problems with medication diversion and abusive practices. We appreciate the rule's aim and that it avoids placing burdensome restriction on beneficiary access to needed medicines, but we'd like to see additional beneficiary protections in any system. Third, we're deeply concerned about CMS's proposed policy to scale back the protected classes. Specifically, CMS argues that existing beneficiary protections, including the Part D appeals process, will preserve access for beneficiaries if open formulary access is relaxed for antidepressants, antipsychotics, and immunosuppressants. Based on our experience counseling Medicare beneficiary, we believe these protections are insufficient, especially the Part D appeals process. Echoing our experience, 2011 data released by CMS finds that over half of plan-level denials are overturned by the independent review entity, the first time an entity other than the plan reviews the appeal. This alarming rate of reversal raises serious questions about how well the appeals process is working and demands greater transparencies. We urge members of Congress to request that CMS make plan-level appeals data accessible so that targets for improvement can be identified. In addition, Congress should encourage CMS to improve the Part D appeals process First and foremost, by allowing a beneficiary to receive a formal denial from the Part D plan at the pharmacy counter, as opposed to expecting beneficiaries and their doctors to submit a formal request to the plan for the denial before the appeals process can begin. Finally, we do believe that pricing is an issue, and CMS is trying to get at that through this proposal. We believe that Congress should restore Medicare drug rebates for beneficiaries that are dually eligible for both Medicare and Medicaid, which would save taxpayers over $140 billion over 10 years. Thank you for this opportunity to testify.
Chair, thanks, gentlemen. And we'll now go to myself 5 minutes for that purpose. Dr. Holsekin. In a recent final regulation issued in April 2011, CMS reiterated the non-interference clause's application to Part D sponsor pharmacy negotiations in its response to a comment, quote, as provided in Section 1860D-11 of the Act, we are prohibited from interfering with negotiation between Part D plans and pharmacies, end quote. Dr. Holsekin, you were at CBO during the time that the Part D program was operating. How did CBO interpret the non-interference clause that Congress passed in 2003?
Well, we were asked on numerous occasions what would happen if the non-interference clause were to be deleted from the law. And indeed, shortly after its passage, this is a letter from January 23rd, 2004, we wrote a letter to then Majority Leader Frist, which said that striking the provision would affect negotiations between drug manufacturers and pharmacies and sponsors of prescription drug plans. So there's no question that it covered the pharmacies, and there's no question that the kind of action that CMS is proposing in this rule is at odds with the intent of Congress.
In the proposed regulation, CMS has reinterpreted the federal law such that, in my opinion, contradicts the meaning of the statute. If CMS to give them records access?
Certainly they could, and I don't know what the outer bounds are, Mr. Chairman. I'm proposed in this rule, and if they are to go forward with this and not see it struck down by the courts, which I think very well would be, then there's nothing they can't do to the Part D benefit.
Could CMS set?
They certainly could.
Could CMS require participating pharmacies maintain stockpiles of certain drugs?
Yes, they could.
The Office of the Actuary at CMS produced an analysis of the estimated budgetary impact of the proposed rule. Yet they acknowledged in conversations with committee staff that not all elements of the proposed rule had been scored. Well, Milliman actually did a complete cost analysis by surveying drug plan sponsors and PBMs to evaluate the anticipated effect of the rule on the Part D program and found it would cost billions of dollars. Do you believe that the American public deserves a full cost accounting from CMS on this issue?
I do. I believe this rule is so sweeping as to essentially constitute new law. The Congress asked for budgetary analysis from the CBO before it enacts new law. I think the same thing should be done in this case.
Offering only one. So let me ask this. If two of my constituents are enrolled in two different enhanced benefit plans offered by the same PDP, one of those two seniors will lose their current prescription drug plan under the proposed rule. Isn't that correct?
That is correct, and in my written testimony, we have an estimate of the number of seniors who would be affected in each state.
Well, I don't think CMS should be outlawing seniors' current prescription drug plans by placing arbitrary caps on the number of plans that can be offered. CMS should not be taking away the prescription drug plans that seniors rely on today. Do you agree?
I agree with the principle that seniors should be able to choose. That choice is an important part of our society. I want to emphasize one of the things I said in my opening. You can't look at that in isolation. The ability to have more plans gets you more volume and lowers the cost of the program as a whole. And I think the CMS analysis is fundamentally flawed by ignoring that.
All right, thank you. Chair, I recognize the ranking member, Mr. Plone, 5 minutes for question.
Thank you, Mr. Chairman. I wanted to ask Mr. Baker, when Part D was enacted into law, many of us were skeptical the program would work. In fact, we were opposed to turning Medicare over solely to private insurance companies because of concerns with gaming and the ability to fully protect beneficiaries in these plans that may be more interested in corporate profits than patient well-being. Nevertheless, once Part D became the law, Democrats put aside the reservations and have worked hard to ensure that patients get the best deal possible under the law. And I would contrast this with the way the Republicans have behaved since the enactment of the Affordable Care Act, actively trying to undermine implementation of the law and keep consumers from getting access to important program benefits. However, the Affordable Care Act made a number of improvements to Part D. Most importantly, it filled in the donut hole, and the ACA also made a number of changes to the Medicare Advantage program, ensuring that consumers and taxpayers get good value for their dollars. So, Mr. Baker, could you talk briefly about the way the Affordable Care Act has improved Part D and Medicare Advantage for beneficiaries?
Well, once again, you're absolutely right. The closure of the donut hole has been a great boon to people with Medicare Part D coverage, and we hear about that on our helpline. As well, with regard to the changes in the Medicare Advantage program that have been implemented through the Affordable Care Act. I note the wellness visit that is now covered, preventive care that is now covered, the prohibition about charging higher coinsurance or copayment amounts for care like skilled nursing facility care or chemotherapy care. This makes sure that there's no gaming amongst the plans in trying to provide disincentives for folks with, for example, cancer, a history of cancer, from joining certain plans, from consolidating offerings. Once again, as Mr. Blum referred to in Part D, but also in the Medicare Advantage program, there has been a constant effort by CMS under the Affordable Care Act to make sure that plans have meaningful differences. And so that has helped consumers understand the program better and use the program better, I think. And finally, the out-of-pocket cap that CMS has implemented in the Medicare Advantage program has provided seniors with, I think, great security in knowing that, yes, they have co-payments amount, but their co-payments amount in Medicare Advantage plans, but they will be capped at a certain amount out of pocket. And I think that has done a lot to make the program more attractive to seniors. They flock to Medigap plans in the context of original Medicare because they see a lot of financial security there for that first dollar coverage. I think many now see the out-of-pocket maximum in Medicare Advantage as a similar financial security measure, and so that's made the program more attractive.
I know that you expressed significant concern with the section of the rule related to categories or classes of drugs of clinical concern in which identified classes of drugs require Part D plans to include all or substantially all covered drugs on their formularies. And you're aware CMS has indicated that these protected classes of drugs were not necessarily meant to be permanently protected, recognizing on the one hand, in many instances, as generics become available, broadly mandating that every drug be available may not make sense. But on the other hand, new classes of drugs may need to be deemed protected to ensure patient access. And as such, the Secretary was directed to establish criteria by which identified classes, including new classes of drugs, for inclusion under the protected status. I know you're concerned about the Part D appeals process. Can you just basically describe some of the problems that you see with the current appeals process, and why, if the appeals process is not fixed, the protected classes proposal would be especially problematic for patients?
Yes, I'd be happy to. First off, this issue that I mentioned earlier about when folks go to the pharmacy counter, they get a denial, and in effect they are told their drug is not going to be covered and be dispensed to them, but that is not a quote-unquote actual denial by the plan. It's not a coverage determination. They then need to either go home or otherwise call or email or somehow contact the plan to actually get a coverage determination and denial, and this can take a lot of time, can take a lot of calls. So we're really calling for that denial at the plan counter to be the denial or coverage determination that does help them initiate and allow them to initiate an appeal. So that's one issue there. There are also then at least two levels of redetermination that the plan has in addition to that denial at the pharmacy counter. We believe that could be slimmed to get to the independent review entity sooner. I think also we're also concerned generally that there's not a lot of data about how plans internally are dealing with appeals, and we think that information, some of it could be publicly available and could help consumers gauge whether or not plans are doing a good job by those who have problems with the plan's determinations.
All right, thanks a lot.
Chair now recognizes Vice Chairman of the Subcommittee, Dr. Burgess, 5 minutes for questions.
And I thank the chairman. I would offer for those, I mean, there have been comparisons between ACA and the Medicare Modernization Act from 10 years ago. There are some significant differences, of course. The Medicare Modernization Act was not the coercive, broad, overreaching legislation that the ACA was. There was difference in scope and size, and thus the implementation, while there may be similarities, there are also vast differences. Mr. Schmidt, just like you, I was, to say I was blindsided by this rule would be an understatement. I thought things were working reasonably well. I don't understand the discussion, why we're even having the discussion about dispensing with any of the 6 protected classes. I mean, Dr. McClellan came here and very patiently in 2005 and 2006, very patiently went through developing those classes. I think you heard Dr. Murphy talk about on the psychiatric side. I've discussed on the immunosuppressant side. You've very eloquently discussed on with the antiretroviral drugs why these are important to have these as protected classes. And I really cannot, and I did not hear from Mr. Bloom why there was a reason for doing this. So I agree with you. I am completely blindsided by the rule. Dr. Holtz-Eakin, I mean, Chairman Pitts asked you this to some degree already, but let me just ask you again, what, in your opinion, what was the original intent of the non-interference clause?
Its intent was to make sure that on both sides of the negotiations, the plans had the unfettered ability to negotiate aggressively with drug manufacturers and structure their plans and their pharmacy networks to attract the volume necessary to get good deals with the manufacturers. And the idea was to keep the Congress and the administration out of those negotiations.
So if we're doing away with the non-interference clause, perhaps we're instituting an interference clause? Would that be a logical assumption?
I view this as direct interference in negotiations. I don't see any other way to read it. If I negotiate with you and then turn around and the CMS orders me to give him the same deal, that's a pretty clear interference. I don't understand that.
Well, of course, Congress loves to interfere, so don't give us an opening.
I would encourage you to restrict those impulses, please.
Well, that's of course why we're having this discussion. But it would, I mean, that interference. Then, if we label that the interference clause is going to have an effect on the direct cost of beneficiaries, is it not?
It is. I mean, the core cost are the pharmaceuticals, and the deal that can be cut with the manufacturers is at the heart of the cost of the program. Things that impair the ability of plans to cut good deals are going to raise the cost to everybody, beneficiaries, taxpayers. It's going to show up somewhere.
And I was going to make that point. It's not just the beneficiaries. Obviously, the person who's ultimately paying the bill, which is the United States taxpayer, or our generations to follow, since some of it's not paid for immediately, they will all be affected by the institution of an interference clause where none existed before. Is that a correct statement?
That's correct.
So the proposed CMS rule suggests that for a competitive market to function, that Center for Medicare and Medicaid Services, has a duty to ensure that there's a competitive market and encourage elements to promote competition. So maybe as a professor in economics, you can tell us how this interference would promote competition.
I don't think it's pro-competitive.
Well,
I
it
mean,
would
if you
promote
think, for
competition
example,
between members of Congress, wouldn't it?
you know, the idea that any pharmacy should be able to provide the terms negotiated between a plan and its preferred pharmacy network. There's already competition. Anyone can right now go to any pharmacy and get their prescription filled. They might not get the terms from the preferred network, but they can go. That forces those who are not in the network to compete on non-price grounds. Service, variety of things in the store, whatever it may be. That's how economics works. For them to step in and interfere undercuts that competition.
And I don't mean to interrupt you, but at time we'll draw short. And that competition is what gave us the $4 prescription at Walmart. And then other chains followed suit with that. Those are indirect effects of the Medicare Part D law that oftentimes don't get, no one discusses.
Yeah,
now,
I think that's one of the reasons it came in under budget costs. I mean, we thought the competitive incentives were quite strong with CBO. We did, but a couple of things happened we didn't anticipate. One is we never had any trouble getting sponsors to enter. There was a fear of having to have government fallback plans. Those were priced in there. None of that ever happened. It's the power of the competitive incentives. And the second was the network sides. The pharmacy and the savings in the pharmacies were bigger than we expected.
And just as a consequence to that, I mean, and Mr. Blum testified to the fact that costs came in lower, he thought because of generic prescribing. I will tell you that I think that generic prescribing existed because of the so-called coverage gap or donut hole. Now that we've done away with that, or we'll do away with that in future years, what's going to happen to that driver that kept costs low?
Well, I know you're over, but briefly, I don't think his reading of the record is correct. The biggest difference between the projections and reality was lower enrollment. Fewer bodies are cheaper. And that's the top thing, not generics. Generics are in there. But there was a lot of generic substitution anticipated because a lot of the patented pharmaceuticals were going to go off patent over the first 10 years. We knew that. So that was priced in at the outset. That's not really a surprise in the data.
Very good. Thank you, Mr. Chairman. I'll yield back.
Chair, thanks, gentlemen. Now I recognize the gentleman from Texas, Mr. Green, 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Baker, you've heard from Mr. Holtz and Egan's testimony. Certain estimates suggest that a large number of beneficiaries would lose their current plan due to CMS's proposal to level the playing field for pharmacies wishing to offer preferred cost sharing under plans' preferred network. To me, this doesn't sound right. Expanding the availability of pharmacies can often reduce cost sharing as long as they can meet negotiated price only seems to expand access to other places. And it's reasonable to expect that allowing any pharmacy to match the competitive prices offered by preferred pharmacies would result in more competition and better access to lower priced drugs for seniors. It also would seem to help beneficiaries who prefer to retain trusted relationships with community providers at their local pharmacy, as well as beneficiaries who do not have nearby access to a big box retailer. And my question, Mr. Baker, can you confirm this line of reasoning? Has it been your experience that all beneficiaries can currently access preferred networks and preferred pricing, or are some of them left out in the cold?
It is our experience that some, in our written testimony, our longer written testimony, we do talk about a woman in Maryland who did not, lost access to her local pharmacy because they were not able to provide the preferred pricing that she could get at another pharmacy where she had not had a 40-year relationship with that pharmacy. So we do believe that opening up, just as we have any willing provider in the general networks in the Part D plans, opening up that any willing provider in preferred networks will expand options and access for consumers, and we certainly are supportive of that proposal.
So you agree with helping beneficiaries get access to more pharmacies that provide reduced cost is good for those patients?
Yes, I do.
Okay. It seems that pharmacies who have contracts today really don't want to compete with community pharmacies who are prohibited now. Would you comment on this? Wouldn't allowing participation of any pharmacy who can meet the plan's terms and prices actually help competition and improve access for patients?
I think that, certainly, as Mr. Holtz-Eakins was saying, there are other components on which pharmacies can compete at, such as service, et cetera, what's in the front of the house, as it were, and not at the pharmacy counter. But we do believe expanding access by allowing community pharmacies and others to be able to match preferred prices will spur further competition and certainly increase access and decrease costs for consumers and hopefully for the program itself.
Well, I think I remember, because I was on the committee when we did this in '03, it was a very long markup, similar with the Affordable Care Act, and I think there was an amendment to this effect that was part of that. And I'm trying to, I'll go back and look at the records, but I understand that, you know, when we deliver health care for doctors, you know, the office visit is basically the same. You know, if you go have a certain procedure, it's basically the same. And now, granted, we do have preferred providers on certain things, but that's through an insurance policy, not necessarily through Medicare. But anyway,
Mr. Baker, I wanted to ask, I didn't get a chance, that while you have concerns with the protected classes policy, you still do believe that many of the other provisions in the rule that protect patients should go forward. Is that correct?
Yes, we do.
All right. Thank you. I yield back.
Chair, thanks, gentlemen. Now recognize the gentlelady from North Carolina, Mrs. Elmers. 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to our panel. Dr. Holtz-Eakin, I have a question for you that is North Carolina specific. I'm very concerned with the number. I think with this proposed rule has a potential of affecting over 500,000 of my seniors. Do you know how many of those health care plans, I mean, in your numbers and in your research, do you know how many plans will be eliminated as a result of this in North Carolina?
We have an estimate that we'd be happy to get to you. When we did our analysis, we found out the number of beneficiaries in North Carolina. We then looked at the plans in North Carolina, and especially the large plans. We could identify those that had preferred pharmacy networks that would be eliminated, or other plans that would be eliminated, and we can get that to you.
Great, thank you. I'd appreciate that. You know, back in, there was a Milliman study done, a survey analysis in January 2014, CMS Medicare Part D proposed rule, found that approximately 12.9 million Medicare Part D beneficiaries currently enrolled in preferred pharmacy PDPs may experience material premiums and cost-sharing increases in 2015 as a result, on average because of the proposed rule. Do you think this is right, that 12.9 million seniors will be affected this way? What are your thoughts on that?
It doesn't surprise me. I don't know if the precise estimate's the right one, but if you change the terms the way the rule proposes, there's not really anything known as a preferred pharmacy anymore.
Yeah.
So a plan can't go to pharmacy.
Pretty much just goes to, yeah.
Right, and so they can't cut as good a deal. The cost sharing will go away, and the prices, the net price to consumers will go up.
Which is, you know, exactly what, you know, I'm hearing today as we're, you know, doing the subcommittee hearing, is there are two, you know, trains of thought that somehow we're going to be saving money, and yet it's contradicting each other, that by doing this we're actually going to be saving money, and yet we keep seeing that it's actually not going to be the case.
Yeah. I would just say to the committee, I mean, you know, this issue has these two sides, which is you want to be able to take terms of a contract to another pharmacy if you can. Wouldn't that be great? But can you cut a deal with as good a terms, and how does that balance out? There's been a lot of work done by the Federal Trade Commission, whose sole mandate is to identify pro-consumer aspects of competition, and they have found these preferred networks are very effective in helping beneficiaries and consumers, and I think the committee should look at it, and I think CMS should look at that work.
Thank you. Mr. Schmidt, I just, you know, in my years as a nurse, certainly one of those groups of patients that I have had the honor of taking care of and come to know, and their families come to know, are our HIV and AIDS patients. Are a vital voice in how much treatment has advanced for our AIDS patients. And I just want to ask your opinion with the provisions that are being put forward
they're not proposing to eliminate, access to antiretrovirals. But as I mentioned in our testimony, we're just concerned we could be next. And, the criteria that they came up with, was very arbitrary. The 7 days, initiate medication, that will result in hospitalization or disability for a typical patient. They're not looking at a Medicare patient. Yeah, we are very concerned and for the future and the harm that it could have to patients. But most immediately, it would have harm to those who need immunosuppressants and antidepressants, and in the future, antipsychotics. And as I said in my testimony, a lot of people with HIV also have mental health issues.
Yes.
And so, around 50%. So we're very concerned about access for medications for them. And then my organization also advocates for people with hepatitis who undergo liver transplants, and they need immunosuppressants as well.
Absolutely. Thank you. And Mr. Baker, I just have a quick question for you. The proposed rule changes, CMS actually pointed out that, there was in this discussion that has already gone forward, and hopefully we're going to be able to have enough time for future discussion. Although I think that time is falling short. The safeguards that are in place. Do you feel that these patients are being safeguarded enough? And as we have discussed, the idea that we're actually saving money. I mean, some of CMS's own findings are showing that this is not the case. What do you say to that? And I'll just make one point that CMS put forward April 2013. It basically pointed out, it said negotiated pricing for the top 25 brands and 25 generics in Part D program at a preferred retail pharmacy is lower than a non-preferred network pharmacy. How do you justify the position that we're actually going to be saving money when we're already doing that, but by making these, this proposed rule change that we'll end up saving more money?
I think, there are projections on both sides of the ledger, as it were, from various actuaries. I mean, we certainly think that given the track record that Part D has had thus far and the stewardship that CMS has been engaged in, that the proposal will lead to lower costs not only for consumers but also for the program itself. And so I think, and that's because of the any willing provider that has been in the pharmacy network overall. We're thinking that same will happen in the preferred network.
So we're projecting that, but we aren't seeing those results. So
well, there's a lot.
Thank you, and I apologize, Mr. Chairman. I've gone over.
Chair, thanks, gentlelady, and now recognize the gentleman from Maryland, Ms. Sarbanes, 5 minutes for question.
Thank you, Mr. Chairman. Thank the panel. I wanted to talk first about the consolidation idea, which I think is a good one. I know the premise of Dr. Holtz-Eakin's perspective is that if you reduce the number of options that are available, that undermines competition. That ends up being a problem in terms of better prices for the program and a better set of offerings for the beneficiary and so forth. But in order for there to be a competitive environment, the people making the choices have to feel that they can choose one over the other. And my understanding, Mr. Baker, is that the evidence suggests that when seniors have that opportunity to make a change, they're so typically overwhelmed by the number of options that are available that they just choose to stick with the plan they have. And the competition that you want to encourage among the providers, among the plans, is both with respect to any new beneficiaries that are coming in, but also more so with the existing pool, because that's the bigger part of the opportunity. So if as a practical matter, seniors are coming and saying, well, I'm in this plan, and yeah, I could go choose a different one, but I'm not going to sit here and go through all of these different offerings, then the market's not really working. I mean, the assumptions that your perspective are based on don't hold. And so if you reduce and consolidate this dizzying array of options that are available, you may actually get more people choosing something different, which will send a signal to the plans that are offering these opportunities that they have to compete more robustly. Now, moving to the issue of the preferred pharmacy providers and so forth, I think it's outrageous that you have independent community pharmacists that are essentially being locked out of the opportunity to participate in a preferred pharmacy network, even when they're willing to accept the same terms. And the way that's happening, and I had the benefit of a pharmacist in my district in Halethorpe, which I represent, a fellow named George Garmer, who actually came and sat with me and kind of took me through his experience. And it may even be that the Maryland woman you're talking about was one of his customers, because it sounds very much the same. But she really couldn't stick with his pharmacy because the way the co-payments were being differentiated between those who were able to be in the preferred pharmacy network and his situation meant that she was going to pay another $300 a year if she wanted to continue to go to the pharmacy that she'd been going to for 40 years and where she had a relationship. So getting to this issue of the market and how it works, there's the theory and there's the practice. And I noticed that in your testimony, you made the statement, Mr. Baker, that with this kind of pharmacy provider network manipulation, plans distort market behavior by lowering beneficiary cost sharing, where the full cost of the drug is the same or higher than it would be at a non-preferred pharmacy. And this is important. Instead of harnessing the power of consumer choice to lower costs overall by aligning lower cost sharing with lower total costs, the plans divide the interests of individual beneficiaries on the one hand and the Medicare program on the other in order to increase the profits of related entity mail order pharmacies. That's not the way it should work. And I just want to give you another opportunity because I feel pretty passionately about this, just based on this particular constituent who came and brought it to my attention. If you could speak again as to why this is a distortion of the market that we're supposedly trying to encourage here.
Right. I think the distortion is exactly as we said, and that is that these lower cost sharing for beneficiaries into these preferred networks is not matched by, in many instances, in some instances, by actual lower prices for the program. And so you're, steering, if you will, beneficiaries to higher cost pharmacies that are either chain pharmacies or pharmacies that are wholly or partially owned by the plans themselves, and plans are reaping and pharmacies are reaping profits from that. We really think that the interests of the program and beneficiaries should be aligned, not only for lower prices, but also because beneficiaries care about the sustainability of the Medicare program and of this benefit, and to the extent that there can be that win-win, and also at the same time allowing community pharmacists into the equation to provide the services that they've been providing, you have more access at lower prices.
My time's up, but I'll just note that if you have more transparency, it will promote better alignment, I think, by definition. Thank you.
Chair, thanks, gentlemen. I recognize the gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you, Mr. Chairman. And Mr. Chairman, I appreciate you having this hearing. And this is one of those hearings where it has put me into a dilemma of sorts, because I have great concerns that CMS doesn't have the authority to do a lot of things that they are doing in this rulemaking process. And I noted with interest, Dr. Gingrey earlier brought up the report from the CRS, and one of the things that he didn't mention is that, what they are attempting to do is to take the legislative language and shift an and to an or, and that causes me, as an attorney who believes that the agencies ought to do what the law says, and if there's a problem, come back to us, that they ought not be changing the law unilaterally, and that they ought to be exercising the constitutional prerogative of bringing their suggestions and their recommendations of my colleagues on this side of the aisle. On the other side, I represent a fairly rural district, And while it may be lowering the price somewhat to have the preferred network, if the preferred network, the chain pharmacy, is located 20 miles away and around the other side of the mountain, I have people who aren't being adequately served by this program. And so, gentlemen, I ask you, how do we solve that problem? How do we solve the problem where we may be getting the price down, but we're making it very, very difficult for my constituents to get to see the pharmacist who's prescribing their drug, and who, you know, in these rural areas, particularly a rural mountainous area where they may not have but one pharmacy, and if that pharmacy is not in that particular town part of this preferred network, and they have to go to the next town over, it may be a good distance, and particularly when most of these folks may not really like getting out and driving, particularly as we've had this winter a fair amount of snow. How do you solve that problem? And I don't mind putting a bill in if that's what you think we need to do, but I do think that, Dr. Holtz-Eakin, it may impact the pricing somewhat, but there's a big difference between walking down the block in New York City and getting from Hayside to Clintwood.
I agree with that completely, and I'm not familiar with their district, so I won't pretend too much knowledge, but we don't have to solve all problems with the same provisions. I mean, the overall goal of this should be to get prescription drug coverage at as low a cost as possible for beneficiaries. I mean, that's a key feature of the design. Now, which vendor delivers that, I don't think we should have a stake in. Perhaps mail order is better for some of your folks as opposed to traveling at all. Have it delivered to their home. We need to make sure that we have a system that allows the negotiations to be as intense as possible with the manufacturers to get prices down, and then use a variety of delivery mechanisms to get them to seniors. And I think that should be. We should trust the seniors.
Well, and of course,
to figure that out.
the problem with, in all fairness, with mail order is if you have questions or if you've had a little rash that might have been caused by that, your pharmacist is in a far better position than your UPS or mail deliverer to explain to you that, oh, well, that is actually one of the side effects buried way down in the notes I have here.
I would concur, and
so
I
that's
almost
the
never have
concern that I have.
UPS discussion. But I guess the second thing I'd say is not all competition is on prices. We do want low prices, but there are many services associated. You know, advice about prescriptions. People are worried about seniors being in the right plan. Well, you know, we trust people to make choices right up to the age of 64 on the exchanges, and 65 suddenly they're incapable. I think they can probably figure it out, but if they can't, they could talk to their pharmacist. Am I in the right plan? This is what I typically have. You know, there are some other aspects.
I am running out of time. I do want to give Mr. Baker an opportunity to resolve the dilemma, and you may want to touch on how the CMMS has a legal authority to go forward with what they're doing, even though I agree with you on the any willing provider portions.
I think that two things. One is that certainly there is a balancing here. In the example that we have in our testimony, it was a $300 difference. So, I mean, I don't think the service component allows that person to afford the $300 at their local community pharmacy. So I think, once again, the any willing provider is I think a moderate solution. I mean, I think for two reasons I'm the wrong person to ask about the interference piece. One, because I am a lawyer, but I don't think qualified to do this constitutional interpretation.
But you do agree there is a difference between and or. As a lawyer,
yes,
you know
I agree with that.
Yeah,
I will agree with that.
Absolutely. And so that's my concern, and I hate to cut you off because I'm running out of time.
Sure.
I have other concerns about both the rule and the fact that maybe it is time for us to take a look at some of the things that may be working to a disadvantage. I have another letter here from one of my pharmacists who's in a specialized area, and they can't even figure out what they're going to get paid until after they've already provided the drug because of the way the system's set up. But I have to deal with that another time because my time is out. I do appreciate it. I've been this hearing totally, Mr. Chairman. I've been educated even more on this subject matter, and do appreciate it, and that's why we have these discussions, and it's good to have. Thank you, sir, and I yield back.
Chair, thank gentlemen, and we will provide questions to you if you'll please respond in writing promptly. I remind members that they have 10 business days to submit questions for the record, and I ask witnesses to respond as promptly. And members should submit their questions by the close of business on Wednesday, March 12. Dr. Burgess, you have a unanimous consent request?
Yes, Mr. Chairman, I have an opinion piece from June of 2012 that almost prophetically foretold the problems that would be visited upon the Part D program by the Affordable Care Act. I'd like to submit that for the record. A very insightful piece that was written.
Without objection, so ordered. This has been a very informative hearing, very important issue. Thank you very much for your patience. Without objection, the subcommittee is adjourned.